everyone. I hope you had a wonderful day yesterday. It was a great start to the conference, and the evening was very rejuvenating. Did we have a good time? Excellent to hear that. So all fresh and ready for today's sessions, I'm hoping? Great. So welcome to day 2 of the IHH Healthcare International Quality Summit. After yesterday's deep dive into quality, innovation, and sustainability, we're shifting gears today to explore the engine that drives healthcare, operations and services. To launch our discussions for today, I'm pleased to introduce Dr. Jatinder Arora, the Chief Operating Officer of the Bangalore Cluster at Gleneagles Hospitals, India. Dr. Arora.
Thank you, Nikita. Good morning, everyone. Welcome to the Operational and Service Excellence breakout session at 9th IHH Healthcare Summit. It is a privilege and honor to open this session where we will explore the critical aspects of both operational and service excellence in healthcare. Today, we gather to discuss innovative strategies and share insights on enhancing efficiency in healthcare. Our focus will be on learning from diverse sectors and applying these lessons to improve patient care, streamline our processes, and elevate service standards. We have an exciting lineup of speakers who will guide us through various healthcare models. Each session is designed to inspire us to think differently and implement changes that drive excellence in both operations and service. We will begin with an exploration of healthcare models, followed by a discussion on enhancing operational efficiency in pre-hospitalization care, which is very important to reach at hospital. We are also excited to learn from other industries. Experts from airline and hospitality sectors will share valuable insights that will help us to rethink and improve our processes. These perspectives are key to broadening our understanding and achieving greater efficiency in healthcare. We will also hear a fascinating session on Six Sigma from famous Dabbawalas, demonstrating operational efficiency without the use of artificial intelligence. Finally, a panel discussion will bring together esteemed leaders to discuss optimizing healthcare workflows and how we can implement these strategies to enhance our own practices. I encourage you all to engage actively and share your thoughts as we work together to push the boundaries of operational and service excellence in healthcare. Thank you for joining us today. Let's make this session both enlightening and impactful. Thank you so much.
Thank you. Now, we're about to embark on a journey through the intricate tapestry of healthcare models. Who better to guide us than Dr. Nachiket Moore, a visiting scientist at the Banyan Academy of Leadership and Mental Health, visiting professor at the Indian School of Business, and he's also commissioner on the Lancet Commission looking at reimagining India's health system. Dr. Moore is not just a scientist and an economist, he's a visionary who sees healthcare as a complex puzzle waiting to be solved. His innovative thinking and deep understanding of the systemic challenges has been instrumental in reshaping healthcare delivery for underserved communities. So buckle up as we explore models of healthcare with a man whose ideas will surely revolutionize our approach. Ladies and gentlemen, Dr. Moore.
Thank you very much for inviting me to speak to you all today. As has been said to you already, I'm an economist, not a doctor, and I will talk to you from the perspective of an economist to, help think about where some of the issues that we in this country face, India face, and where I think some of the solutions might actually lie. At more than 35,000, both have the same number of close to 70% out-of-pocket expenditure. And there is a lot of evidence on the ground that our responsiveness of our health system is actually quite poor, which means we as a country, if we are to aspire to offer what they call UHC or universal health coverage, we have a long distance to travel. This is, of course, well understood. For those of us who live and work in India, this is not news. Every day in the newspapers you hear about what are the challenges. The question is, can we ever get to this goal? Do we have the resources to do it? And what do we need to do to get there? And this is what I'm hoping to talk to you a little bit about. My belief from my research is that I believe, and I will try to persuade you, that we have the resources that we need. The challenge for us is design of the health system. How have we thought about converting this, whatever resource we have, into something that delivers outcomes for the people of the country? Let me begin with financing, since I am an economist. One of the first questions that any UHC discussion asks is, do we have the money and the people to serve our population of 1.4 billion people spread out over a landmass of 3.3 million square kilometers? It's a large country with a number of people. Our research, and we have a Lancet paper on this. My speech, by the way, I have shared with the team, and if anybody's interested, all the references I mentioned there, suggests that because healthcare is a highly labor-intensive sector, unlike steel, paper, cement, people are the core of healthcare. India has an unusually low cost structure as far as human resources is concerned. And multiple studies tell us that if I now were to convert the Indian rupees buying power in healthcare dollars, the exchange rate to use is actually 5 rupees to the dollar, not what IMF says for the PPP basket, which is 20 rupees, and certainly not the nominal 80 rupees. And this, if you look at data, and we have a lot of such data from medical tourism, from other calculations people do, it applies to advanced cardiac heart surgeries, where there is a fair amount of capital used, certainly all the way down to primary care. Which then tells us that if a government is spending 2,000 rupees per capita at a nominal exchange rate, it looks like it's just $25. And you might say at $25, what are you talking about? How can we deliver universal health coverage? But if I were to use the exchange rate I just argued is more applicable, we're talking about $400. Countries that some of you are familiar with, for example, Thailand, was able to deliver, and Turkey was able to deliver universal health coverage to its citizens at less than half that money, almost 20 years ago. Our research suggests that if you take other ways of thinking about it, not just the exchange rate, one of the directions we went was that we said, what if India were to take the newly published Indian Public Health Guidelines, 2022, this came out 2 years ago, and built an entirely new health system from scratch at market prices. Hired all the doctors, built all the hospitals, built all the primary care facilities. We again come up with a number that is closer to 2,000 rupees, 2,500 rupees per capita at 2018 prices. Of course, these numbers can change quite a bit. The government has just released yesterday or day before the new National Health Accounts 2022. So we now have new numbers that tell us, if I take that estimate of 2,000 and use 2022 prices, the number is 2,500 rupees per capita. At that price, there are only 6 states in which the government does not spend enough money. And these are, of course, the states that you would imagine, Bihar, Jharkhand, Madhya Pradesh, and Uttar Pradesh. And they will need central government allocations. We are hoping to persuade the Finance Commission that as a part of their deliberations, when they file the next commission, they provide the extra money that these states need, well within the envelope of what the Finance Commission can do to bring them up to what these 4 states need. All of that together suggests to me money is not our principal problem. I'm not saying it's not a problem, but it's not our principal problem. We have enough money. Our governments are spending enough money, not just our people, which are spending much more. And there are states like Goa, Delhi, Himachal, that are spending 2.5 to 3 times more than is required from the government kitty. Let's go to human resources. It's a much more complex question, obviously, as you all know better than me. But if we choose to build a health system, and there are some academics that have argued that we should copy what the British have done and build a health system staffed by MDs in family medicine in every village, because the UK GP serves about 1,700 people on average per GP. We are going to need 300,000 family medicine MDs willing to work in a rural area. If we take that approach, we clearly do not have enough doctors. And we are not likely to have enough doctors even by 2050. Psychiatrists, for example, we estimate, currently we have about 10,000. We expect in the next 25 years, what is available on the ground in India will be 20,000. For a population of 1.5 billion people, with the model of a psychiatrist will provide you counseling services and directly engage with patients at the first point of call, this is not a possible direction to go. But we know that with protocol-based approaches towards diagnosis and prescription, the most significant challenges in healthcare, in much of healthcare, particularly at the primary care level, are not diagnosis and prescription. It's relatively easy to say with a simple glucometer, what is your blood sugar level? Yes, it is random. It's not quite HbA1c. It's not precise to the level that you might want, but it gives you a good indication that if somebody has a 300, you know that there is a problem and they need to begin treatment. And there are good protocols approved by the government, approved by doctors that one can start using. For hypertension, for example. These are the bulk of our diseases. There are clear protocols that can be used to give you a prescription and to decide what the treatment plan would be. The challenge in primary care, as many countries that have successfully dealt with primary care, is not prescription and diagnosis, is one, to have people seek the care that they need. You find in many, many states, I was just giving an example in a conversation of the state of Kerala, district called Pathanamthitta, 25% of adult population has active diabetes, which is not diagnosed and not treated, right? To the point where the concern is in the next 5 to 10 years, we will see an epidemic of amputations in these because of diabetic foot. Every home will have an amputee. And this is some of our richest states, richest districts. Right? That is the challenge. As doctors, we might say, I just gave a prescription. If the patient didn't adhere, it's not my problem. Unfortunately, good primary care is not about that. It also needs good home-based care, because often patients can't travel, patients don't want to travel, and given the remoteness, Iran has been able to offer in rural Iran really high quality NCD services using exactly these types of workers, because they recognize follow-up, going to the patient's home, chasing them, is the mechanism by which we can actually make this work. There are projects, for example, going on right now in India, because these are international examples. You might say, what about India? What's going on here? Not yet of the scale that you would notice yet, but sufficiently large, 10,000 patient population, 50,000 patient populations, in which what they call digital doctors, these are doctors not sitting on the field, are collaborating with health workers on the ground to make sure that they are showing high levels of hypertension control. Up to 75 to 80% of the population that is hypertensive is now showing full control. 70 to 80% of the population that's diabetic is now showing full control. Hypertensive crisis patients are dealt with within hours, if not days, of the crisis actually occurring for the first time. Right? In field settings, relatively quickly, and with good access to tertiary care when needed. If you then combine this approach, with a very judicious, and I want to emphasize judicious, use of pharmacists. France, for example, does all its vaccinations in pharmacies. They have a high density of pharmacy in that country. India has twice the number of pharmacies per 100,000 population than France has. They have roughly 1 pharmacy per 2,000 population. We have 1 pharmacy per 1,000 population. If we use the pharmacy well, if you combine that with using the family members, because in India the family is intact, the family is a powerful force, and there are organizations like Noura Health that are working with families to train them, for example, in post-discharge care. I was given an example of cardiac surgeries that you're doing on neonates for congenital heart disease, training the mother to look after the infant before the infant is discharged reduces readmission rates by 80%, because mothers know now what to look for, and they can go back to their remote villages or wherever they came from with the doctor not being concerned that the patient will actually not be well taken care of. And then, of course, we have advanced point-of-care technologies that are starting to emerge that we can use. So far, I'm speaking only about glucometers and sphygmomanometers, but there is a lot more on the horizon that we can give to the hands of these workers. We don't have the butterfly ultrasound yet because of PCP and DT issues. There are people working hard to mask the image entirely so that AI engines are able to give you initial indications of what might be an issue. If, for example, I'm able to detect vascularity in a lump that I detected on the breast, I know that there is something wrong and that I need to refer this person up for consultation. I'm just giving you one example of where an ultrasound could be quite helpful. In fact, people are starting to use vascular Doppler to try and help us understand early what is going on in the breast. Right? So there are many things that are coming up. It gives me confidence that if we make this work well, and there are many projects going on in the country that are experimenting with this, primary care is something we can deal with quite effectively, even without the family physicians that we need. You might say, okay, but that may be true for primary care. What about more advanced care? How are we going to deal with advanced care? There are emerging models of what they call collaborative care that are starting to work at secondary care levels, not tertiary, but certainly secondary care levels. I'm involved in a project that what it's doing in the Northeast, and we've done 150 hospitals now, district hospitals, government hospitals, building a tele-ICU service in which MBBS doctors, you do need MBBS doctors, you can't do this without at least some level of medical capability in the district hospital, working with super specialists at the back end, are able to offer very high quality ICU services and stabilize patients, treat patients under supervision from specialists sitting at the back end in remote areas. I believe something similar in Nepal is going on for psychiatric care, advanced psychiatric care. Again, the bed is in the district hospital, the psychiatrist is sitting at the back end, and again, working with combination of video, protocols, and all these technologies, one can bring a lot of capability to the front end and use the specialist resources in a very parsimonious manner and reduce, once again, the consumption of specialist talent to what they actually need to do. So a psychiatrist now is no longer dealing with 3 patients, but is dealing with maybe 5,000, 10,000 patients via this larger structure that is implementing protocols. And if we are able to build good primary care of the type that I spoke about earlier, we have the idea of gatekeeping. You can make sure that people don't show up at a hospital. If you go to any public hospital in India today, including right here in Bombay, it looks like the whole city is arrived there, right? And if you interview them, one of the large hospitals had asked me to do a project to look at this exact issue. It turns out almost 95% of the patients are in the wrong place. This is not where they should have come for their first conversation with a doctor. There are many other locations much closer to where they live that they should have gotten that service. Of course, they are here because they didn't get what they needed to get. Right? Thailand has implemented quite successfully the idea of gatekeeping and keeps a lot of the patients' occupancy rates pre-reform in Thailand, like India, for 140, 150%. Patients in the corridor as well. Today, they are 60%. Much more reasonable, much more manageable, leaving 35, 40% capacity available for emergencies. There's clearly an opportunity for us to address both primary care and secondary care. Tertiary care, of course, will need to run like the way you are all running it right now, but what happens now is the load is for truly specialist care, advanced care that is going there, and not routine in the system. One of the questions that comes up is, okay, maybe financing is there, maybe we can solve the HR issues. How do we organize the care so that indeed all of this capacity becomes available to people when they need it and at prices that they can manage, they can think about? I'll talk a little bit about what some of the debates we are. As was mentioned earlier, I'm a member of the Lancet Commission. We are also exploring these ideas in the commission itself, and hope to present those ideas to the larger audience sometime soon. Our submission is undergoing review right now. We know, at least from what I've presented so far and from other research we have done, is that the best way to build good healthcare systems are not combative healthcare systems, where patient interest, payer interest, and provider interest are not aligned, and they're constantly fighting with each other. Right? A patient shows up at a hospital, he or she doesn't know, is what the doctor telling them in the best interest of the patient, or is it something that the insurer whispered in the ear and said, don't recommend this, otherwise I will not pay you? Or is it that they are somehow making more money out of doing this procedure? I don't really need it. Same issue with the payer, same issue with the provider. Provider is saying, patient doesn't know what they want, they're just saying some random thing. The payer is preventing me from doing what is needed to be done. The best health systems have tried to align the incentives of all of these in one place. Right? How have they done it? They have built much higher levels of integration between primary, secondary, and tertiary care, which is vertical integration, and as well as horizontal integration, which payers and providers are often integrated into one structure. If you have just one provider, we call it, there are many names. One name is managed care. If you have multiple providers and you follow Enthoven's principles, it's called managed competition. And you see many European models now that are successfully implementing fairly aggressive managed competition model. Israel has one of the countries in which the entire health system is paid for by the government, but delivered by 4 managed care providers who compete actively with each other to provide the business. And there is good evidence that it is a reasonable way to proceed. One might argue, is it perfect? Does it offer the solutions completely? No, there are challenges. If we stay with this idea that alignment is what is needed, I'll just go quickly through the 3 types of providers that we have. One is the public sector. In India, the public sector today is the only provider that is fully integrated from primary care all the way to tertiary care. No other provider has this capacity. Largest hospitals don't have it, small nursing homes don't have it, and certainly individual primary care providers don't have it. Unfortunately, despite that integration, despite financing and care, all of the ideas that I mentioned earlier being integrated, it has not delivered the kind of care that it's supposed to do, because it is lacking one major component that is needed to make managed care work, which is it's not under competition with anybody else. And benefits denial is one characteristic of managed care systems, and you'll see this often as something that people express a concern about from the public sector, that they don't have the services, they don't have the medicines, they don't have the doctors. All of this constitutes one form or the other of benefits denial. The approach that has to address this issue that has gained momentum globally is not to expose the public sector to competition, though some people have done that as well. Most countries, and again I'll give you 2 examples, Thailand and Turkey, have used what they call the purchaser-provider split, in which, starting with what Mrs. Thatcher did with the NHS trusts, the departments of health have been told, you will no longer get money automatically annually from the government. You will be a delivery entity like any other delivery entity. We will create a third body. In Turkey, it's called the NSO. In Thailand, it's called NHSO. Everybody has a different acronym for it. In India, we do have something called the National Health Authority and the state health authorities. We can easily function as purchasers that are arm's length purchasers who are buying from integrated health systems, not procedure by procedure by procedure, but on a population basis. And this purchaser-provider split has become gradually the standard that the public sector reforms around the world have gone with, which means you get the benefit of integrated care, but you get the accountability that comes from the fact that the money comes to you only if you deliver outcomes. If you don't deliver outcomes and you have a 5-year period and that runs out, then the government and the purchaser will start to look for other alternatives to replace you or find another way to improve your performance. The corporate sector, from something that you're all familiar with, it's focused mainly on tertiary care, but it has found its growth prospects very limited. because of the very low penetration of insurance in the country. Only 6% of the population has retail health insurance, individual health insurance, growing virtually at a zero pace. Much of the increase you see in premiums are actually just price increases. You're not seeing the underlying population actually insured growing, and there's about 8 or 10% group insurance via the corporate, which is about 16% of the market. Given such a small market of insured people, tertiary care is going to very quickly face limits. Your hospital systems are doing well, but if I look at it from a system-wide perspective, I see growth rates in tertiary care hospitals barely tracking inflation, maybe a little bit ahead of inflation. And the unfortunate reality is that even that small growth is coming with high occupancy volatilities. Your RPOBs are shifting up and down. Your occupancy rates are shifting up and down because the market is just very tiny and everybody's competing with each other. And the net aggregate in a 10 trillion rupee market, 10 lakh crore market, the total share of the corporate sector, 5%. Really very, very small. I have been a banker 25 years. I have never seen a sector in which the corporate sector has such a tiny market share. I'm used to 60, 70% of the total market being owned by the corporate sector. Steel, cement, paper, hotel, that's the reality. It's unusual to find a large sector which is such a tiny market share. The only way to fix this is to move much more quickly towards managed care designs in which you're not waiting for people to show up with 5 lakh rupees, 10 lakh rupees in their pocket to pay for their services. Because the insurance penetration is very low, but to launch your own managed care plans and to start to take responsibility for the healthcare of the people that you serve. If you were to take any of your hospitals, draw a radius of 5 kilometers and ask yourself the question, what is the share of revenue of total healthcare spend of this market that I have? My suspicion is 0.5%, 0.75% is a number. You need to take that number to 60%. The only way to do it is for every one of them to have membership in a plan that you have launched so that people know this is the right place to go to and they can actually do something else. And you might say, well, what if the public sector reforms and everybody has universal health coverage? What we have seen is the need for supplementary insurance, the need for people to want better care that they pay for is actually quite high. Even in a country like UK, which has had universal health coverage for a long time, supplementary insurance is where a lot of the private sector starts to operate. And of course, the public sector is a long journey. There will clearly be gaps that are available. There are also technology platforms that have emerged now. You would have heard from some of them already. Unfortunately, what they have done is they have simply mimicked the offline process and just made it online. If the primary care is fragmented, instead of switching the primary care to become continuous, comprehensive, trusting, they have simply made it easier to make it more fragmented so that you can search quickly across providers. And post-COVID, they have seen their growth rates collapse because beyond a point, people don't find the value in this 5-minute conversation with a doctor in which he or she said something, half you understood, half you didn't understand, and then you're supposed to now act on it. It is very important for these platforms to move away from these approaches if they wish to grow, not simply to serve the people of the country, if they wish to grow, and to either start to work with primary care providers as their primary clients, or alternately start to think about how do they build continuity between different transactions, using concepts like digital twins that allow you to take episodic encounters and stitch them together into a continuous process. And clearly, this is an opportunity that is available. People have done it in the world. There is an opportunity for us to do it. And technology, as we all know, is one of our strengths. And it's possible that with these digital twins, we may discover an entirely different pathway. The public sector, what I mentioned to you, old hat. Britain did it in the 1980s. Managed care, old hat, 1990s ideas. Right? It's the third one that could be uniquely Indian, that could be something that really does something quite powerful, but it needs a re-engineering of a different type. To conclude, my own belief is that India has the resources that it needs. It has the money, it has the purchasing power. A nurse in India, You might pay them more, but on average, a nurse in India costs about 2 lakh rupees, 2.5 lakh rupees to hire, fresh out of school. The same nurse costs in the US close to 80,000 US, implying an exchange rate of 2.5 rupees. So clearly, we have the ability to produce manpower at a price that people just cannot compete with. The data is actually quite strong on it. We use that manpower well. We use that human resources well in ways that are much more structured, much more gradual. Don't waste it. If you put an MD family medicine in every village, great idea. But that scarce talent you would be wasting. And even assuming they show up there, right? That's another entire different kettle of fish. But even if they could show up there, I don't think that is a good use of their capabilities and what they can actually do. There are many others that can provide this. I believe not only can we provide good healthcare to our peoples, but with technology, with our strengths on things like landscape epidemiology, for example, using satellite data. India is one of the few countries that has geostationary satellites. Many developed countries can't actually say that. Instead of taking an idea from elsewhere in the world and trying to cut and paste it here, what we economists call suitcase models. You went somewhere, you said, oh, what a lovely system, let me just come and cut paste it here. If we build something that is uniquely our own, we can do better than many developed countries have done. One final component, though, I want to make sure that we don't forget. Right? The Indian disease burden, I just gave the example of Kerala, is actually underlying very high. I also work, you saw I am a visiting scientist at the Banyan. I also work in mental health. I'm trying hard to think about things like suicide, underlying issues. If we wait for all these people to show up at hospitals, what happened in COVID will happen to us. The only reason we are not flooded today is people are too poor to show up. But let's say we gave them all insurance, we'll get flooded. There's no way we can serve this population of the country with the disease burden that it has. We have to think about what can we do outside the hospital. And it turns out that there are many, what I would call, free lunches available. Let's take cardiac health. Most people are like me, lots of central adiposity. Right? We know central adiposity drives insulin resistance, converts hypertension into diabetes at a very fast pace. Food is not the solution to central adiposity. Routine daily exercise is the key issue. How do Parisians with their high butter-filled croissants get that exercise? Because they have good sidewalks and they have good public transport. You have to walk every day to get to work. You have to walk every day to get back home. Building good sidewalks and public transportation is the way forward for cardiac health. Cities have to do it anyway. Why not do a good job of it? Why make a mess of it? And then people are taking out their two-wheelers. The number one driver of road traffic injuries, another public health problem, are two-wheelers. And you could put, I think Malaysia, Indonesia have done a terrific job of separating two-wheeler traffic from motor vehicle traffic. But no matter what you do, accidents will happen if you have such a mass of two-wheelers. We have this unique phrase in public health. In road traffic incident, it's called looked but did not see. Right? What it means is I'm driving along. I tried to make a left turn. There was a motorbike there. I looked for it. I didn't see it. Right? For some reason. Right? Clearly, these things can make an enormous difference. I was speaking earlier about building codes. If you see some of the newer buildings come up in Bombay with the Slum Rehabilitation Act, they are so close to each other. Researchers are finding that the rate of conversion of latent tuberculosis to active tuberculosis is accelerating in these cities. We're not able to deal with the active tuberculosis burden that we have right now, and we are experiencing multi-drug resistant tuberculosis, right? 40% of the population has got latent tuberculosis. Imagine if that population starts to convert to active TB, changing the building code and insisting that buildings have a certain separation, which we had earlier. Those of you that are from Bombay, I would invite you to go to Prabhadevi and visit the Bombay Development Department chawls, the BDD chawls. They are built in 1926. Take a protractor with you. The angle that the eye makes when you stand outside one chawl to the ceiling of the next chawl is 63.5 degrees cent. That angle, for a variety of reasons, 100 years ago, was believed to be the right distance between the two buildings. No TB in BDD chawl. Lots of other problems, but no TB. So clearly there is an opportunity here to build some of this stuff. Salt substitution, I am doing a training program with the Odisha government. I find underlying hypertensive load is enormous. Diabetes is not so enormous. The tribal areas of Odisha don't have diabetes, but the coastal areas do. That's a separate problem around, insulin resistance and all kinds of other things going on, with pear-shaped bodies. Right? But salt consumption is universally high. Salt substitution, salt reduction, these need strong public health campaigns. Right? And of course, tobacco is a problem Gujarat is facing. Young people all over the country are facing. These are all issues in which we can start to implement. I was recently approached by an online gaming company. They want to build a healthy mental health perspective gaming environment so that the industry is respected, industry is seen to be a part of entertainment, building good mental health outcomes when you might have seen anxious young people coming back from school. Half an hour of gaming, the brain has calmed down, right? But that if half an hour becomes 6 hours, well, that's an entirely different new problem. We know now some things about, for example, CDRDS, the dopamine deficiency that is starting to create addiction and addictive personalities. Right? Other things we can do, again, outside of hospitals that can allow us to build this stuff. So thank you all. I want to leave you with a note of optimism. All of this is possible for us to do in India. It just needs action on our part. Thank you.
But first, I just wanted to say, wow. That was an absolutely amazing talk. And I think if I was sitting glued to my chair, I think the pin drop silence in the room is evidence enough that it made a lot of sense to all of us. So thank you. Before you leave, I'd like to invite on stage Dr. Ashutosh Raghuvanshi. He's the MD and CEO of Fortis Healthcare to present you with a little token to mark your presence here today. Thank you. Now we turn our attention to an often overlooked aspect of patient care, pre-hospitalization. Enter Mr. Prabdeep Singh, the founder and CEO of Red Health. With a career dedicated to redefining emergency medical responses, Mr. Singh combines the heart of a healthcare innovator with the precision of a strategist. He believes that the first moments of care are as crucial as the procedures that follow. Today, he'll shed some light on how we can enhance operational efficiency before the patient even steps into the hospital. Please welcome Mr. Prabdeep Singh. Oh. Really nicely. Will you do us the honor? Wonderful. Please.
Hello. Prab is a fantastic speaker. Unfortunately, he's become unwell. He's woken up with a massive headache. I was just on the phone with him. He's right here in this very hotel, I presume, but he's not able to come here and present. But his slides must be available. Are they available? So who am I? Why am I here instead of Prabdeep Singh standing here saying all this to you? I'm a doctor. My name is Tausif Tangalwadi. I don't have a pointer. Right. So my name is Tausif Tangalwadi. I'm a doctor. I've been an emergency physician for a very long time. Thank you. Right. There we are. Okay. Yes. I've practiced emergency medicine in this beautiful country for about 20 plus years, around 25 years. Most of it, I was associated with a single hospital in Chennai called Sundaram Medical Foundation, but then traveled across the country trying to help establish emergency medicine in this lovely country. We are successful today. Amazing emergency departments that your group has. Some of my good friends work with you, old colleagues. Along the way, I decided doctors should get into administrative healthcare. Fortis is a big example. Global is a big example of how doctors have successfully made that move. And I did that as well. I administratively led a hospital for about 5 years and then went on to help build India and the world's first AI-enabled preventive health checkup center. It's called Noora AI, nothing to do with Noora Health though. Dr. Nachiket gave a fantastic lecture. Today I exclusively focus on pre-hospital care through Red Health. I head operations, I'm the VP operations, also function as medical director. So that's why I'm here. All right, so that's the quick introduction. Thank you very much. I made your life easier. Yes? All right. Okay. Yes. So, what did we come here to present? In fact, if there was a question and answer session after Dr. Moore's session, I would have definitely asked him. There were great statistics, very inspirational, insightful, but I didn't hear emergency response. The statistics for emergency response. Yes, the government is working on it. We have Niti Aayog statistics, I know. But from the economist's mouth, I would have wanted to hear how that pans out and what it holds in future for us in building emergency response in India is what you wanted. Okay, so I'm not as great as Prab, but I will try to do my best and show you what this presentation is all about. Okay, right, so this is the story. This is the journey that began. I would have loved to walk and talk, but this is fine. So Red Health, Prab's journey started off with a young man having this idea that why not build a great emergency response for India? And where do these all great ideas come from? Having a personal emergency. So his father, unfortunately, had a chest pain-related event, a cardiac event. Thankfully, he's doing great now. He's quite well. But at that point, when they wanted an ambulance, they were 8 minutes away from a hospital by car. They couldn't find one. They couldn't find an ambulance. This was about 10 years ago. At this point of time, this young man, Pradeep Singh, was doing very well in his career. He had started off from the pharma background, worked with Glenn Saldana, if you know of Glenmark, and then went on to do a double MBA, one of them at INSEAD in Paris, and then was at BCG in Brazil when this happened. And him and his two friends, a Frenchman, Antoine, and a Costa Rican, a Chinese Costa Rican, Jose, they had built a project saying, why not build an aggregator platform where we can bring in all ambulances in India together on a platform so people have one number to dial and then get a high-quality ambulance, right? And that is what led to the birth of this organization called Stan Plus Technologies. Today, we are more popularly known as Red Health, but that's where it came. And the reason why it became Stan Plus Technologies was Stan was Streamlined Ambulance Network, Plus was, hey, we're doing something better. And at that day and age, technology meant, wow, we're doing something amazing, right? So we just added everything together, and it became Stan Plus Technologies. And that's how the birth of Stan Plus happened. Going back. And this is our journey since then, okay? Stan Plus was founded in 2016. 2018, we went on to work in air ambulance because we decided that emergency response and medical transport is not just of road, but also air. So we went on to air ambulance. Red Assist is what Dr. Moore was talking about. People sometimes don't know if they're in an emergency. They have to call up, and somebody has to tell them, hey, don't worry, you're not in an emergency, you don't need an ambulance. Or somebody's telling them, you need an ambulance right now, and I'm sending one right away. And that is Red Assist. A doctor telling people whether they are in an emergency or not and guiding them what to do next. So we went on, we reached about 1 lakh. That was a big jump in 2020. As of now, we stand at 5 lakh plus people served using the ambulances. We are a funded company, so we did seed funding. Seed funding was actually from Prab, Jose, and Antoine's idea that they presented in INSEAD, and they were given 15,000 euros. And that was the seed fund they started the company with. And then we went on to Series A, rebranded to Red Health. You know, there's Red Crescent, Red Cross, and Red Health. It's easy for people to remember Red Health rather than Stan Plus Technologies. And then in 2024, that is this year, we proudly became the first Asian medical transport organization to get JCI accreditation, right? So that's where we went. And of course, we also got Series B funding done. And this is not the only the accreditation that we've gone on to do. We believe very strongly in quality because in today's day and age, when you say pre-hospital care, all of you run fantastic hospitals. Whoever's come from across the world, your hospitals are some of the benchmark that people look up to and say, wow, great systems, right? But once that patient leaves your door, how many of you are thinking quality? Just thinking ambulance, send them home, right? There's no thought. Where's the quality? You are quite responsible for the quality you provide at your doorstep in terms of your own ambulances, but if it's not the 2 or 3 ambulances that you have stationed outside your hospital, you're not thinking quality anymore. And there is a lot of quality that we can bring to medical transport. In fact, our JCI accreditation is only the 7th in the world, and the first in Asia, and the first to be accredited across 16 cities simultaneously in this country. And we don't rest there. We are doing many more things apart from JCI. This is a JCI certificate. We are ISO registered. We have a DBS certificate. We are HIPAA compliant. In terms of quality, we are ensuring that everything that can be provided in a hospital in terms of quality certification, we're trying to see if we can bring it to the field as well. And that's what RED is trying to do. Okay? So this is about JCI a little bit more. I'm the proud holder of that. Well, because I'm the medical director and operations head, I get to say, hey, I led the JCI. But there was a fantastic team of close to 150 people who worked across the country to make this truly possible for us. So that's our JCI certificate. So what it has ensured is we have, we try to have good SOPs, we have standards. We have something called as Project Doctor. We today don't know who's going in the ambulance to serve a patient. We have to credential our doctors and put them in the ambulances. So that's what we're looking at, not just our EMTs and paramedics, but also the doctors we get on a locum, on an on-call basis, also have their credentials stored with us. There's a proper interview process that they go through before we can put them onto the ambulance, right? And this is where we are at this point of time. We have built our ground strength. We are present across 23 cities in India. That's the size of our reach. We have about 150 plus partnered hospitals. I said more than 5 lakh people have been transferred. In this, we have more than 400 ambulances of our own. But the beauty of it is we have a partner network as well. So the technology is where you had an aggregator and people loading their ambulances onto the aggregator still continues. We have more than 5,000 plus partners that we have, and we are pushing in the next 3 months to make that 15 to 30,000. That's a big, large-scale project that we have where we want to bring in most of the ambulance operators in the country onto one platform. Why? What's the point, right? The point is to transfer the quality that we have in our ambulances to them as well. Give them guidelines, give them benchmarking. When we onboard, we tell them this is what you need to fulfill, and then we hope we will be able to transfer quality across India. Now, let's think about a journey of a patient in India, okay? And what is the problem statement that we're trying to solve? Oh, so first, there's somebody who has chest pain. India is, our #1 killer is heart disease, right? Like most other countries, except maybe Japan and a little bit of Asia, where cancer then comes #1. But it's heart disease, chest pain. 50% of our people die from heart attacks. So they have to first wonder, who are they going to call for help? There are a few numbers available. Yes, you can call 108, but that's a predominantly public service system, and it's going to take you to a public hospital, but most of us want to go to a private hospital. So we are wondering, what's the phone number? We're waiting for somebody to pick it up. We say, hey, come quickly. And then once the ambulance is on the way, we're wondering, why hasn't it arrived yet? How many more calls do I need to make? And it's going to get answered either by somebody who can tell me where it is, or they're going to say, I will transfer to somebody else. And when it comes, we don't know what is the quality. Is there really oxygen inside? How good is the equipment? Is it calibrated? How many of us are thinking the ambulance provider that we suggest to our patient has its equipment calibrated or not every year, right? And then the person who comes in, are they trained enough? And when it's all over, you're regretting your decision to not have made all these prep beforehand. Because emergencies don't happen often, thankfully. Maybe once in a lifetime for most people, but in that situation, we're woefully lacking. So this is a problem statement that we had to solve. So we solved it by breaking up our work into 4. Trigger, triage, transport, and treat, right? So trigger is about people knowing when to call and whom to call in an emergency. Triage is us at the so we always, when we think ambulance, we're only thinking the ambulance pilot or the driver and the paramedic. But the dispatcher is the first line. The dispatcher sitting there has to quickly triage you and dispatch the right ambulance. And then the transport happens, and then the treatment happens. And we work on all of these systems to ensure that the least amount of delay is happening. There is a phone number that we have, and let's see, maybe I can, if I have time, I'll get one of you to make a call on it, and you can see how quickly we try to respond to this, okay? So we answer, and then we ensure that our large network of hospitals, which are some of the biggest hospitals in the country, in fact, we run Fortis's hospitals at this point of, ambulances at this point of time for most of their units, but we are expanding across the country as well. So we take them to some of the best hospitals in the country, which are their preferred hospitals, for that matter, right? And then this is all backed by tech. Now, anybody can buy ambulances, anybody can hire drivers and paramedics. Of course, the quality is secondary, but technology, building technology is where the difference was, and that is why I joined Red Health. Before Red, I had by the provider's grace, I had a very distinguished, illustrious career in emergency medicine, but I moved here because I saw the technology that they had. The way they would trigger, triage, and then respond was fantastic. It, in fact, is the world's first computer-aided auto-dispatch. The tech that is built at Red has the capacity, once you say it's ALS, you trigger that ALS button, it can quickly select the nearest ambulance that's available on our portal and then dispatch it automatically. The dispatch trigger goes to the pilot. All he has to do is select and get on the way. No need for a human intervention to say, hey, you have this, there's a pickup, there's a drop location, nothing. Everything, all the details are transferred with that phone call and that click saying it's an emergency, and they can dispatch. Of course, there are other requirements people have. Sometimes they need some help to move them. A wheelchair is needed, narrow lanes, so some discussion may happen. But we are the world's first computer-aided dispatch that we have. Would one of you, please don't, all of you call at the same time, one of you, because otherwise my team is really going to scold me. If you have an Indian number, you can try calling this number and see how quickly we respond. Does anyone want to do this right now? If there is lack of time, then I'll just move on and we'll come back to this number later. Maybe I'll do it personally with you, right? Okay. And of course, this is a dashboard that we have. So I was talking about how our dispatchers can see at all times where all their ambulances are. Some of the developed countries or with more developed healthcare systems, I'm thinking in Southeast Asia, may already have this, but for India, this is something that we want to do, right? My vision is like Iron Man, Tony Stark saying, hey, this is my ambulance. In air, figuring out where it is and enlarging and viewing it. We are there on a TV screen at this point of time, but maybe we'll be able to do it in air as well. So we are there, and we are only at maybe 20x of what we can do. We can scale this up to 50x right now from what we are doing. We just need more hospitals to partner with us and more ambulance on the grid, and that's where we're moving. Right? And security is very, very important for us. Safety is very, very important. We have dash cams installed in all our ALS ambulances at this point of time, and we are moving now to have our BLS ambulances also have dash cams. So it monitors driver behavior, what the driver's wearing, seat belts, so we check if they're on, how are they driving on the roads. This is a real-time video that we can, see minute to minute when the vehicle is on trip. And this is our Red Health Passport. This is the most comprehensive JCI-compliant patient care record that is available in any ambulance anywhere in the world. And this is a big form. When we first made it, me being an emergency physician, knee-jerk reaction is, why is it so big? But that is the amount of data we need. It's a piecemeal form. It gets filled in phases, not at a single go, and we're now digitizing it. In the next 2 months, this will be digitized very intuitively, and a paramedic has to fill this before he can go to the next case. Why am I saying this? Documentation in pre-hospital care in our country is a big problem. We don't know what's happening inside that patient cabin. We take it for granted that whatever the paramedic comes and tells us or the doctor comes and tells us, that is the end of it, but now we are making it all visible. We can see what's happening inside the cabin, and the moment the ambulance reaches the doorstep of the patient, the care delivery starts right then under the guidance of a doctor, right? So we are trying to ensure that. That's why this documentation is super important. This is, okay, different pages. I think that's a video showing you how comprehensive that document is. I just want you to know these are not my slides, right? So I'm like, okay, it's coming up now. Okay, so yeah, that's the comprehensive Red Health document. It has a consent form. It has everything that is needed for quality, safety, and also documentation standards-wise, right? So that's our Red Health Passport. Yes. Okay. And this is a case study. This is our journey that we have right now at Red Health, how things happen at Red Health, right? So there's a distress call, an alert is notified, emergency coordination happens. The call center coordinates either with the ambulance and notifies the next of kin and also the receiving hospital. And there is an AI-enabled questionnaire. This is also existing, but this happens after the dispatch. Once we know it's an emergency, the dispatch starts, and then there is a further question, an intuitive AI-based question which says, oh, they have chest pain, ask these next few questions. So the dispatcher doesn't have to keep everything in their head. They can use the AI to do this. What are the tasks for the next of kin? Again, is AI-guided, so they will do that. The dispatch has happened already. The paramedic is briefed on the condition of the patient. Then the dispatch is also sent in case there are any special requirements. The ambulance prep is done. The device is integrated. So I'll show you something that we have also built. It's called Salus EMS, which, like I said, can take care to the doorstep of the patient. We plan for patient admission. The ER doctor is already informed. They can get their stroke team, cardiac team, whichever team, trauma team ready if they want. Updates are given, audiovisual communication, and then they reach the hospital. Entire team is prepped. So we try to ensure that the care is started the moment the ambulance reaches the doorstep, and also through community engagement, maybe by the relative itself. If I'm a little too quick, I apologize for that. And this is Salus EMS. We are very, very proud of Salus EMS. Salus is the Roman goddess of wellness. Why did we choose the Roman goddess? I have no idea. When they told me Salus, and then she's the goddess of wellness and health, I said, which country, which religion? Right? We have 3 lakh gods in India, so I needed to know that. But apparently it's Roman, and we are doing that. Right. So Salus EMS, built from scratch by us. It's hosted on a secure, web secure that we have, and we also developed it not just for 5G, but for 3G or slow internet as well. So it's not, connected ambulances don't have to be 5G ambulances. Even at low internet strength, they can still remain connected, is what we want to build. And it's HIPAA compliant as well, the data transfer that happens, right? Okay, so what is Salus EMS? Salus EMS is an entire fleet management and an ER management tool that an ER doctor has in their hands, right? So there's a call that comes in. The ER doctor on the Salus screen can see how many ambulances are available to him or her, and then click dispatch. The ambulance goes. And from that time onwards, they have an ETA that is tracking to them. Ambulance on its way to the patient. Once the ambulance reaches the patient and the monitor is connected, they start live streaming of vitals with 0 latency. We had a tough time getting this built in, but we have succeeded. It's 0 latency, second by second, as the vitals happen. We get the vitals to the ER doctor sitting in the ER. So effectively, we've not just sent an ambulance, we've sent an ER bed out to receive the patient, right? And then they know what is the ETA of the patient coming in. They can do, and then this is the case sheet that has all the vital signs and data, patient details, demographics, everything is there on that, and then there's a log, sorry. I want to show you at the left corner, if you're seeing, every decision made, every instruction given is a log. Connect, call, everything is logged. So data security and seamless integration into EHR is thought of in this. And then there's a video call system. So there's an audio-visual communication wherein the doctor can talk to the patient as well. So that's Salus EMS for us. So 5G, when we say it's only for the audio-visual, and the quick streaming of the vitals is where the only added bonus, often a very good internet network can come in, so that there is 0 latency and also the audio-visual communication is clear. But the rest of the documentation part and the fleet management can work even without a high-speed internet connectivity. And that's what it is doing, right? So faster decision-making happens, and teams are ready when this happens. And that's the screen that's there. Of course, we are going to keep making it better and make it look more beautiful. The idea was to give the doctor as seamless integration into the ER screen as possible. So they should feel, I'm looking at 10 screens, my 11th screen is right here. Only thing is my 11th screen is moving out and in, right? So it's moving, but the screen is the same, and I know exactly what to see on the patient. And that's the video screen where they can interact and connect. Right. Our future, where we want to head, is something that we call machines calling machines. A lot of you today must be wearing wearables, smart devices, as we call them wearables, right? And wearables are getting better and better. I remember about 8-10 years ago, I think it was Qualcomm here who had a global competition saying, with a wearable device, how many parameters can you measure on the human body, right? Like temperature, heart rate, and so on and so on. And so wearables is going to be a reality for all of us. We are going to wear it, especially the elders at home who are alone when we are either at work or living in a different country or city, right? Supposing, God forbid, an elder falls, right? They may or may not be in a position to pick up the phone and call somebody in an emergency. So the machine can call a machine. So we built this side of the platform where we are ready to receive the call and do an auto dispatch. We are now trying to integrate with wearables of different brands to ensure that when there is a trigger, we are able to pick up and then dispatch quickly without as least a human interference as possible, right? So that's the future that we are moving towards, and all of this is a step in that direction. Right. Okay, and Red Assist, of course, like we said, these are different things that we have in Red Assist, right? Red Assist, we are moving towards, of course, I don't know how to say it, it's a women's safety app, yes? Wherein, let's say you feel threatened, and you know the police of the country is also doing this in India, you just have to press a button, and all the necessary support that you need is available to you. And this safety app, we call it EADOC, we call it Red Assist, can also give you timely updates on disasters that are going on, accidents that are happening. So you have a good clarity of emergency response systems as well as emergencies that are happening around you. Okay? So that is about Red Assist that's there. It helps you. All of this is our proprietary tech. We have been talking to employers who are very pro-employee health and safety and wellness. ESG is a big part of most corporate companies today, and we are happy to be a part of that. So we are giving them a workplace emergency management with Red Assist. And again, this is also being built in-house. So the aim is to be an entire end-to-end emergency response company. It's not just about medical transport or medical logistics, it's emergency response. And that's why I said when Dr. Moore was talking, I would have been so happy to look at the data he had on emergency response, because it would have helped us know if we're in the right direction or where we should be spending our time and energy. So this is what Red Assist does. It's an SOS button, like I said, immediate rapid response that will happen. And of course, that's the disaster alert, rain alerts, company alerts, right? So like for instance, there's a disaster happening somewhere and a company wants to tell its employees, stay at home or don't travel to this place. Okay, today the weather is like this, be careful. Well, the Red Assist platform allows them to do that, and it's intuitive because from the news, the company gets the alert, the company decides what messaging to give their employees, and the employee gets the message. And you can consult a doctor. Obviously, we're building all our existing capabilities into one. You have emergency response, you have doctor assist. Why not build it into your safe workplace, right? So we are bringing all of that together. So that's Red Assist for us. And then we've moved on to something called as Red Family Protect. In India, there's a unique problem. A lot of our young workforce is now working abroad. You know, some of the biggest companies are led by Indians. You know, that's great for us to be proud about, but also that means a lot of their parents are living alone in our country. Yes? So Red Family Protect is an end-to-end, not just emergency response, but a concierge service. The elder goes with them. So when there's an emergency, there's an SOS button that's clicked. We go there, pick up the elder person. We take them with us to the hospital. We function as a concierge. In the absence of an attendant, we ensure that the admission happens. How are we able to do this? First, we already have an SOS button. The SOS button gets triggered. Second, we already are connected to all the hospitals and the big ones where they are. And we have already done a pre-visit checkup where we have visited them about, as soon as the subscription happened, we've gone there, we visited them, we know what is their preferred hospital, and we can take them. And we're connected to the hospitals already. So like I said, we are putting all the pieces of the puzzle together to build as many different end-to-end systems for emergency response as possible. And that is Red Family Protect. And it's a dedicated helpline number. There's a dashboard to track all the services. We promise 25 minutes. I wish we could promise 15 minutes, but you know, India, traffic, roads, there's a different problem that we are trying to resolve, and hopefully that will change as better and better cities and better updates happen to our country's roadways, which is in the process. So that will happen, and priority access and a medically trained concierge. That's how Red Family Protect happens. So yeah, this is the whole journey of what happens when you subscribe for Red Family Protect. So you sign up, we call you, we visit your family, and you're all set, right? So it does not start with the emergency response. It starts with the subscription, and there's already a visit before the emergency response, and there is a curated list curated by our doctors where we take in data which is important for our emergency response. So the first visit happens, and then on, we are ready and raring to go in case they need help, and they're always there. And the help need not always be for emergency. Sometimes, you know, elders need to just go for checkups to hospitals. That also can be facilitated. Right? All right, so these are the people who trust us today in the country. It ranges from some of the biggest hospitals, names that you know and are familiar with, to some big corporate companies that are there. We're also working with some big public sector units that are there, and they're working with us not just as an emergency response provider, but also as knowledge partners. They want us to help them train their doctors in emergency response, work with them closely on disaster response, because we are now trying to bring the entire emergency response healthcare system under one umbrella. So disaster response also can be faster and better. So we are working with them on many of these things. Right, thank you. And I didn't even know that was coming up. Right. Thank you so much. I apologize for the last-minute impromptu substitution, but I guess, unfortunately, he was really, really unwell, so I had to step in. But you would have enjoyed Prob's lecture, maybe probably 20% more than you would have enjoyed mine. Thank you so much for your patient listening. Thank you.
Yeah, thank you very much. Yeah, thank you very much for a very nice and lucid presentation. I am Air Marshal Pawan Kapoor, and you know that in the defense services, we are the quickest response in any emergency. I want to ask you two questions. Number one, how do you credential and privilege your paramedics? And number two, do you have any training facilities to ensure standardization of care across the spectrum of emergency responses?
Fantastic question, sir. Thank you so much for asking that question. This is something that is very close to my heart. Apart from being an emergency physician, I've been a very strong academic across these 20 years, traveling and teaching across the country. So one thing about paramedic credentialing, India currently has, and I'm going to quickly make this about 2-minute long answer, India has different modes of paramedic training. We have anything ranging from a 2-month paramedic course to a 1-year to 2, 3, 4-year paramedic course, and across all spectrums. And then we have nurses also who function as paramedics. So what we have done is we have set a benchmark. The minimum qualification that we'll take is the 1-year paramedic course at the least with experience, or a 2, 3, or 4-year paramedic course that we can. This is the standard that we have set. We don't stop there. This is just the basic entry point for qualification, which we have now made very objective. We have an assessment test. They have to score above a certain percentage to be even eligible for the interview. Then we have a 2-step interview where one paramedic and one clinician interviews them before they get into the system. So this is what we do. Once they're in the system, we then train them. Weekly, twice, we have something called as grand rounds, where clinical topics. We have about 44 clinical practice guidelines, thanks to JCI, that we have implemented, and it's there. And they get trained on these CPGs and also the JCI-related IPSGs, the patient safety goals that are there. So we train them on that as well, and it's an ongoing process. So that's how we try and ensure that their standard continues to go up. When we partner with hospitals, the one request we always have to have with them is, please allow our paramedics to work with you inside the ER, right? So that they don't get de-skilled and they're continuously aligning with the protocols of the hospital. So these are some of the ways that we try to ensure that high-quality paramedics are there. But we are not resting on those laurels. What we are doing is now we are moving towards something that we are calling Red Academy. Red Academy is our next venture. The government has a BWalk course, a vocational course. It's a 3-year program. We are trying to see if we can get universities affiliated with the BWalk Emergency Care Technology course. And once that's there, we are going to start recruiting students into that course and start training them ourselves. This is our next goal. We hope this will become a reality in the coming year, in the coming academic year, and we will be we will be recruiting students into the BWalk course and then training them ourselves to see if we can create little more standardization is what's happening in our field. That's what we're doing. Thank you so much for that question, sir. Thank you.
Thank you, Doctor. I think you've raised the bar on stand-in presentations. I think that was very, very well done. So thank you for that. May I request Mr. Dilip Kadambi to step on stage and present you with a little... Oh, is there another question? Oh, sorry, I don't think we saw your hand. Apologies. Can someone hand her a mic, please?
I just want to inquire. Healthcare comes with a cost, right? So what sort of a cost are we looking at with this rate assist?
My bad. Just got too excited there. Okay. Red Assist, the main cost is building the tech, hiring all these tech engineers to build it. That's expensive. But so the capex is very, very high. It goes into a few crores, and most of our funding goes into building our tech. But in terms of OpEx, it's only the call center employees. We have about 75 plus. We have about 100 call center, assistant center employees, we call them. And we have about 5 doctors on our roll who are handling these calls. And that's the cost of the Red Assist for us in terms of operational expenses. But CapEx is very, very big for us. Traditionally, pre-hospital care in India has not been looked as a revenue-generating model at this point of time, but we are trying to see how we can work closely with hospitals and government agencies and other companies to see how costs can be shared, and working on a model that seems to be reasonably working at this point of time. That's why at this point of time the funding becomes important, but we hope to become a profitable venture at the earliest and not be reliant on funding.
So what's the transportation cost when a person makes?
It varies from city to city, and also varies from whether you're asking for a basic life support ambulance to an advanced life support ambulance. Generally, our average cost is in what people, we serve from a varied of 0 to 1 kilometer to probably even 1,000, 1,500, 2,000 kilometers, right? So the average number for a basic life support somewhere will be about 2,000 rupees, starting from as low as 800 rupees and going higher. And for an advanced life support, it will be about 4,000, 4,500 rupees is where it would be. But again, that also starts from as base as 2,000, 2,500 to going up. That's how that really works.
Thank you.
Thank you. Yes, sir. Last question, sorry. Okay. Yes. Thank you very much, Dr. Harish.
Because you're at different cities, including tier 2 and many other probably where facilities are not that great, how do you look at standardizing your protocols across with times, the TAT meeting as per the major cities, because you're also JCI accredited? So that's a challenge. So what is the solution now, or probably how will you get there?
So that's a fantastic question. That's a huge pain point, because when we went through the JCI exercise, we made our ambulances compliant. Then we reviewed them 2 months later, and they were non-compliant, right? It's like, okay, what just happened? And it's a lot of cost involved trying to standardize things. So we have, at the background, been building things that we call, Prab loves to give great names. I'm very bad at names, but he's given names like Red Optimus, Red Flash. These are our incident identifying and ticketing system that allows us to quickly audit our ambulances on a daily basis and then raise tickets and have turnaround times that we're tracking to close them. And it's, again, audiovisual enabled, so we try to ensure that we get there in terms of standardization. I wouldn't say we are there yet, but it's a daily process and we're trying to get there at the earliest, and that's how we are working. Right? Thank you. Thank you.
Thank you for that. So may I please invite you? He's the Group Chief Financial Officer at IHH Healthcare. Thanks. Thank you. Staying to schedule, our next session takes us into the clouds, quite literally, as we explore learnings from the airline sector for healthcare. Navigating the healthcare landscape can sometimes feel like flying through turbulence, and who better to guide us than Mr. Manoj Chako, the founder, managing director, and CEO of Fly91. With a wealth of experience in aviation, Mr. Chako knows a thing or two about customer service and operational efficiency, lessons that are as applicable on the ground as they are in the air. Today, he'll share how the principles of aviation can help us navigate the complex skies of healthcare delivery.
Good morning. After two absolutely fabulous sessions, it's going to be a huge challenge for me to actually keep this audience interest alive, especially on a topic which is possibly not something which, is part of your day-to-day routine. But yeah, it's actually an absolute honor and privilege for me to be here, in front of you, talking about an industry which is known for a lot of interesting stuff, if I was to put it as mildly as that. But let me kind of give you a very quick introduction on who we are and what we do. So Fly91 is a small little regional airline. We are based in Goa. Goa is, for those of you not from India, Goa is about 500 kilometers down south on the west coast. And we are headquartered in Goa. This is an airline that was set up about a year back. We commenced operations 6 months back and set up by myself and a couple of aviation professionals. And the focus is actually on bringing what we call the last mile connectivity in India. India is a large country, and India is the second fastest growing aviation market in the world. What India lacks is connectivity into the smaller towns and cities. And that is really where this country is growing. So our entire vision was on actually setting up an airline that can actually get into the nooks and corners of the country. Just to give you a perspective, India's got over 1,000 aircrafts on order, but not a single regional aircraft. Most of 90% of Indian aviation is focused on a concentrated set of city pairs. Okay, so that's really where we saw the opportunity, and we said, let's get into it. So this has been a personal journey for me, and I want to share some of my learnings on, how this journey has been, and hopefully bring in some kind of, insights which could be similar. As we speak, we completed 6 months of operations. We fly into some absolutely fabulous destinations, some of the destinations you're familiar with, like Hyderabad and Bangalore, and maybe Pune. But we also fly into a place called Agatti, which is beautiful Lakshadweep Islands, again on the west coast. One of the most beautiful islands that you'd actually have anywhere in the world. We also go into a small town called Jalgaon, which I think especially the medical fraternity will be very familiar with, because it's got a huge density of hospitals apparently, and we've got a lot of doctors who actually fly. We fly into Jalgaon. We also get into a place called Sindhudurg, which is very close to Goa. Again, not too many people are aware about it. But interestingly, these are all cities where there is literally no air connectivity or very, very less air connectivity. So this is really where we started off. And a couple of core values that we at Fly91 actually started off with. And I just want to talk about this because it's very important to understand how we went about doing certain things, which helped us get to certain deliverable points today. And just to give you a perspective, in 6 months, we have operated over 1,400 flights, carried over 50,000 passengers, okay, which is actually not a mean achievement. And we operate between 14 to 16 flights a day with 2 aircrafts. But these have been some of the fundamental philosophies that we focused on. So first one is, of course, safety. Aviation, like healthcare, there is no compromise on safety. You can never say that, I can land 99.99% of times. Correct? You've got to land 100% of times. Okay, so it is absolutely paramount. So there is zero compromise for error. There is zero compromise for safety. So obviously to achieve that, we studied airlines around the world. We spent more time studying failed airlines than studying successful airlines. Okay, because you have to learn from mistakes, and you learn from other people's mistakes is always good, because then you don't make the expensive mistakes. And we came up with 4 things which we said are paramount for Fly91. The first one was simplicity. We said anything we do, we need to look at it from the lens of simplicity. And I'll give you a bunch of examples as we go along, but let me just finish the 4 points. The second one we said is, whatever we do, operate with frugality. To set up this airline, we spent 2 years raising capital because we are a capital-intensive industry. We raised $25 million of professional funding through private equity and other investors. And I know the effort involved to raise money. Okay, so once you know the effort involved to raise money, then you also know the pain involved when you burn money. So frugality is a very, very key concept. And I think it's not just aviation. I think in any business, frugality is something that you need to be very focused on. The third one, again, very interesting, is humility. Okay, whatever you do, you got to do it with humility. And that's all the more important for us because as we get into the hinterland, we find that people actually get intimidated. Oh, airline, crew, pilots, So for us, humility is very important because if you can't connect with the local people, if you can't connect with who your customers are, okay, it's very difficult for you to kind of run the business. So that is a very important learning for us. So for example, our frontline staff, we've got no criteria about educational qualifications. You can be a 12th standard pass. As long as you can work hard, you can work at my airport. As long as you meet the regulatory requirements, we don't have a problem. We don't insist on our staff to know fluent English because 90% of people in India don't talk English. Okay, in Maharashtra, they'll talk Marathi, they will talk Konkani, they will talk Hindi. Okay, in fact, our name boards actually got regional languages out there. Like my flight to Lakshadweep, when my crew who speak Malayalam are on that flight, we have the maximum sales of food and beverages happening. When my crew who can't speak Malayalam on board, nobody is buying anything. Okay, and this is real stuff that we kind of keep learning. Very important learnings. And the last most important point is whatever you do, do it with integrity. Aviation is a highly regulated industry, highly regulated. I mean, it's like healthcare. And we are very proud to say, and I've said this publicly multiple number of times, from the day we applied for our no objection certificate to the day we got our license, we are the airline that got it the fastest. Okay, and in that entire process, we did not even gift a 100-gram sweet box to anybody. Okay, so the moment you state to your values, your principles, okay, and all that we said is anything the regulator comes back, correct it, go back, correct it, go back. Okay, it gets frustrating. It is frustrating, it is time consuming, but once you have your SOPs, once you have your processes in place, okay, then nobody can ever question or touch you. So these have been very clearly our core philosophies that we adopted. Of course, when I was approached to talk and say, what are the kind of similarities between healthcare and aviation? These are some of the points that came up. Obviously, it is capital intensive, it's regulated, high degree of compliance. So for us, literally everything we do has to be recorded. I'll give you a simple example. We had, on our washroom, we had one of those knobs that had come off, okay, which is possibly a $50 product, but you just can't pick it off a hardware shop and put it on the aircraft. Okay, you need to have trail documents, you need to have trace documents, correct? Your aircraft could possibly get grounded for a full day because you don't have it, because now you say the lavatory is inoperable. Okay, so the degree of compliance that we need to adhere to is extremely, extremely high. The third one way, there is a lot of similarity, is the need of highly skilled, licensed professionals. Just like how you have the doctors and the paramedics, for us it's the pilots, it's the engineers, it's the cabin crew. And it's not that any pilot can just get into a cockpit and fly. He needs to be trained, he needs to be current, he needs to be trained on the right kind of aircraft. The guy sitting on the left seat and the right seat need to have a particular amount of hours of flying. So there is a huge degree of complexity that kind of come in. Of course, there is uncertain demand. You're never sure about your demand, and your margins are always fluctuating. It's not that, what you put in your Excel sheet about margin assumptions will always turn out true. You need to be prepared for any emergency. Okay, so every time before a takeoff, and it's very interesting, the pilots actually have a checklist which go through right from saying, as I am on the takeoff roll, if one engine fails, below 100 knots, what do I do? Above 100 knots, what do I do? Once I take off, if I have an engine failure, what do I do? When I reach my destination station, if the weather is not good, what do I do? Where do I divert? Correct? And they have to be trained through that over and over again. You can have a pilot with 20,000 hours of flying experience, 35 years of ace pilot. Every 6 months, he has to go back to the simulator. He has to go back with an examiner beside him. He has to prove his ability to manage every single emergency protocol that's written in a book. That is the degree of compliance that aviation has got. Okay, and it's important that we need to kind of follow that. So that's again something for a young airline, it's expensive. Okay, but there are ways and means of how you kind of go about doing it. Of course, technology and equipment is important. And end of the day, it's a customer-facing business. So you are finally facing the customer, okay, and you are in business after all. So while you have all these complexities at the back, it's like, when you walk into a hotel or when you walk into a hospital, correct? As a customer, I'm only focused on the doctor I want to meet. But when I walk out, every single touch point makes a difference, correct? So I may have had the best doctor who treated me, but possibly, the bad coffee that I had, or maybe the way the person at the entrance treated me, could possibly make my decision whether I want to go back there again or not. Same thing happens in aviation. Okay, it's not about the pilots who fly, it's not about the engineers who maintain, it's finally about how do you manage your customer end to end. And this is really where, I want to talk about some of the examples that we did. So one of the first things that we did in Fly 91 is we changed the entire paradigm where we said that, listen, we are not in the service industry. By and large, when you ask anybody in aviation, they'll tell you that, it's a service industry. And we said, no, we are not in the service industry. We are in the air transportation business. The moment you define your core, your entire focus actually starts changing. Okay, so for example, we said, what are the problems we face? Expensive resources, licensed resources, ability to find them, ability to attract them. Okay, so we said, okay, let us solve for this long term. So a couple of things that we have done is we broke down the work to every single process was looked at, and we said, what can be eliminated, what can be changed. So let me give you a couple of simple examples. We are the only airline in the world. We are the only airline in the world that does not have a check-in process. The moment you buy a ticket, your boarding card lands up in your WhatsApp. Okay, because we questioned the status quo. We said, why do you need to go through a painful check-in process? Okay, and the history of check-in processes go back about 50 years. Okay, and again, one of the speakers mentioned earlier, you pick technology and then you take the same technology, you keep recreating it without really going back and questioning the status quo. And we realized that, you can be auto-checked in. So you check in automatically, you got to check out by default, because 95% of people, when they buy a ticket, they're buying a ticket to travel. They're not buying a ticket to cancel. This now eliminated the process where we are the only airline that doesn't have a call center. Okay, so we're the only airline that doesn't have a call center. We are the only airline that actually works on what is called a weight concept and not a piece concept. So today in India, when you fly, correct, they allow you 15 kilos of check-in baggage, 7 kilos of hand baggage. We also allow exactly the same. 7 kilos hand baggage, 15 kilos. It's regulatory. But all that we tell the customers, I don't care how many pieces of bags you bring in. Because the biggest single largest friction point with airlines today is the fight that customers have at the check-in counter. Correct? I'm carrying 15 kilos, but I carried it in 2 bags. I'm sorry, sir, you can't. You got to pay $6,000 for another bag. So we said no, because the additional revenue you can make out of it's hardly anything. So what we did is we said, you bring 10 pieces of bags, 2 kilos each, I don't care. Okay, but people don't do that, correct? At best, they may bring, a few guys may bring an extra bag. So every one of these small things that we introduced actually started making a difference to our cost structure. Okay, because you have lesser friction. Like how I said, I don't have a call center. I've got bots that work informing customers. So the moment I have a delay, as we speak, I have a technical delay. Okay, there's no call center. There are messages going out on WhatsApp. Okay, saying there is a hour and 20-minute delay on today's flight. Most of the time, how many of us actually want to call up any call center? We all very proudly say, I've got a great, I've got an American Express card, we've got the best call center. Yes, I mean, so I've got the best service when I call them. But why do I ever need to call them, correct? Are we dying to call a call center? No. So we went back, questioned the status quo, and these are things that actually start changing your service quotient, number one. Number two, start changes your cost structure. Again, we kind of made sure that from a long-term perspective, we had to actually build out what I would call a pipeline. Again, I take an example between doctors and pilots. Very expensive resources, very difficult to find the right skill sets. Again, like how you have specialists, we also have specialists. We got check pilots, we got training pilots, we got examiners, okay? But what we did is we actually started building a funnel. So today as we speak, with 2 aircrafts, we got 19 pilots flying. But out of the 19 pilots, 14 of them are actually captains. The cost is high, but we've also brought in 25 trainee first officers. Okay, so my average number of hours in the cockpit, I've got a guy with 18,000 hours on the left seat and a guy with 100 hours on the right seat. But this guy with 100 hours on the right seat, by next year, same time, would be having 1,000 hours on the right seat. And when he's got 1,000 hours on the right seat, I then need a 3,000 hour guy on the left seat. Okay, so today, yes, today I've got some of my flights go with 40,000 hours of experience in the cockpit because you've got 2 very senior guys flying. That's because we want to make sure the standards are set very high. But the way we are building our pipeline is 18 months down the line, we will never have to hire a specialist guy in the left seat because we have built the pipeline coming from the right seat. This is something that we learned from airlines like Air Arabia, for example. That's one airline in the region that never has a pilot issue. Never ever have a pilot issue. So these are examples that we pick in. Again, it's about training and retraining. While one of the things that we did is we invested in our own training setup. So this is our own in-house training facility in Goa. We have, again, our regulations are so strict. I just can't take people into a classroom and train. My training classrooms have to be approved by the regulator. So we, as an airline, have got 6 regulatory approved training classrooms. That is actually a real aircraft. It's a real aircraft that is cut up in our office where we actually train our cabin crew. So today we have an entire flow, like cabin crew and frontline staff are like your paramedics. Okay, they have to be licensed. Okay, but we can do the licensing for them. Okay, so we pick them up, we train them. It takes us about 3 months to get them licensed to actually operate on the planes. Okay, but that's the pipeline we are building. We just released our 5th batch of cabin crew, completely fresh kids. Kids from the local community. Again, we are one airline where we don't have any restrictions on, the looks and the height and all of that kind of stuff. There's only one regulatory criteria, which is body mass index. If you meet the BMI criteria, you can apply to fly for us. And if you meet the training requirements, you can kind of go through it. So a lot of training, retraining. And this is my last slide. Finally, it's culture that makes a lot of difference. So if you see if you see the name boards over there, everybody's name is actually written not just in English, but in a local regional language. You can pick the language. It can be your mother tongue. It can be, whatever language that you want. And again, if you notice, whether it's my ground staff, whether it's my cabin crew, they all wear the same uniforms. Okay, so these are small things that we have done. But yeah, it's been an interesting journey, and thank you so much for giving me this opportunity to talk.
Mr. Chaku, you had thrown some bait before you started, very respectfully, on the fact that you were following two such eloquent speakers. I think that you've sort of kept up that tempo, and I think a round of applause for him, please. Thank you so much. Did we have any questions? We can take one or two quick questions if we have any. Oh.
No, it's a good question. So we are working on it because, for example, we fly to the Lakshadweep Islands. We are the only guys that fly between Goa and there. So we're actually working on a retrofit kit in our aircraft, wherein we can actually take a stretcher if need be. So hopefully in the next 6 months we would have that kit. Again, it needs to be certified right from there. But as part of our community program, we are already talking to the local island administration to actually have hospitals and doctors from Goa actually go into health camps. And Lakshadweep has got 36 islands, out of which only 10 are inhabited. So we're actually working with some of the local hospitals to get some of them to go there. But we have a lot of people who come to the mainland for treatment who actually fly on us. So our wheelchair requirements are maximum on that particular sector.
Hello, I'm Dr. Harish. So there are a lot of similarities between airline and hospital. The surgical safety checklist is actually picked up from the airline sector that we use. I have a question. Of course, training can be better in a hospital with airline simulation models, etc. But my question is, what would you say, is it regulatory for you to have a regular checkup, maybe psychological assessment of your staff? And could that be, for improving our clinical outcomes, could that be done in a hospital? Would it need a regulation? Just wanted your take on that.
So there is a whole bunch of, so for example, I have a full-time doctor who works in my office. I have a full-time paramedic that works with me, because every time a flight dispatcher creates the dispatch, before he does it, he has to do a breathalyzer test. Okay, we are supposed to do random drug testing. So we have a room in headquarters where you can pick an employee as is and get drug testing done. But there's a set of people that have to go through the breathalyzers mandatorily, as well as with statistical samples. Also, when it comes to pilots, we put them through a mandatory psychological assessment, which is done because, it's important to understand their state of mind and frame of mind. But that is not, that is not completely regulatory. So the regulator says it is good to have, not must to have. But some of the other things are absolutely, so your annual health checkups, medical checkups, the class 1 medical checkups, the class 2 medical checkups for the crew, these are all mandatory for us.
And also I think incident reporting or its corrective measures is regulatory, which is
completely regulated. So for example, it's regulated to such an extent it's not even funny. So let's say, for example, the aircraft doors shut, and if the doors have to be open for any reason, okay, it has to be reported to the regulator, and there will be an inquiry board, okay, and you have to answer. It could just be a technical, some light is fused, the engineer has to come back and just fix it, okay, has to be reported. So the amount of incident reporting is massive, and it all has to be documented, the language, what you write, what you don't write, what the pilot writes, what the engineer writes, what you put on email, all of that stuff is correlated. So the paperwork is massive, but let me tell you, the Indian DGCA, the regulator, I would rate their standards as maybe one of the best in the world. While everybody looks at FAA and EASA and all that stuff, I must tell you, while they are pulled up for all the wrong reasons, it's one of the best regulator in the world in terms of regulation, quality-wise.
I think that is one area hospitals can improve, incident reporting and its analysis, and I think we can learn from the airlines.
I think it's not only incident, and since you raised this question, sorry, I'll just take 30 seconds more. The focus on fatigue is very important. So we may have to ground an aircraft and not operate a flight if the pilot is even 1 minute above his regulatory mandatory duty time. Okay, and I think again, I'm just talking as an absolute outsider. The fatigue element is regulated in a very, very strong fashion. Possibly it's something that healthcare has to look at. You have surgeons who are working long hours, lack of sleep, coming back. So we do have that absolutely taped up at a very different level.
Thank you.
May I invite on stage Mr. Anurag Yadav to please present a token of appreciation. Now let's check into another domain that excels in service delivery, hospitality. As we know, the hospitality industry has perfected the art of creating memorable experiences. And today, Mr. Sanjay Rai, the strategic advisor at Lemon Tree Hotels, will share his insights on how healthcare can borrow from this playbook. Mr. Rai's strategic vision and hands-on experience have made him a key player in elevating service standards across the hotel industry. His wisdom in applying hospitality principles to healthcare is a game changer, promising to turn ordinary patient interactions into exceptional experiences. What I haven't mentioned is that he was also leading the charge at Max Healthcare, and the bridge that he builds between hospitality and healthcare is what he's going to talk about. So please join me in welcoming Mr. Sanjay Rai.
Respected organizers, respected members of the audience, I can see some familiar faces. I'd like to begin by sort of introducing myself as I continue to evolve as a human being, considering the fact that statistically one may have lived 70% of one's life. So, drawing lessons from Manoj's wonderful rendition, I'd like to say to you as a student of life, for life, and somebody who considers himself as an evangelist of sorts in the customer service excellence space. Several years ago, in my ongoing journey as a professional, I embraced two very important philosophies as a service professional. One was that the two most entities that one must pay obeisance to, one being the organization or institution that bases a brief interaction reposed faith in me. And second, it is the target customer who reposes faith in you. Yes, you need hierarchy, otherwise you need structure, organization structure. You need hierarchy, otherwise some would argue there would be anarchy. But amongst my ruminations before I come to the core subject, and this is just to try and establish a connect with you all, because one doesn't know where our paths will cross again. You're giving me your time, and hopefully I can value add by sharing some thoughts. Difference between manufacturing and service. All of us are in service, I dare say, in this group. In manufacturing, you get second chances. I see a defect, and I can put that aside. In service, you don't get. Clumsy me, sorry. In fact, in service, the product is born at the time of impact. I don't have anything in front of me. In my journey as a professional, I happened to fortuitously get an opportunity to work in the healthcare space. I must say it was a very, very interesting experience. But one of the things that I used to agonize over day in and day out was the disconnect between the credo of the brand, which said caring for you for life, but the experience that actually played out from this entity called patient. I have a disconnect with this term. I hope the healthcare space will eventually, sort of move away from this title called patient, because my insight was that the difference between healthcare target audience and a consumer who buys products and services from other spaces is the state of the mindset. Anyone calling up a healthcare establishment, be it through a telephone call or through an email, or presenting himself or along with attendant fraternity in person, is distress-stricken, is anxiety-ridden. And therefore, one morning, the penny dropped into my mind that if doctor and non-doctor internalized in the truest sense that entity, patient and attending fraternity, is my own relative, what is the kind of service rendition I would mete out? And ladies and gentlemen, so this is how I've sort of, as a student, learnt some perspective on this. Manoj talked about humility, he talked about frugality, he talked about all those things, which brings me to a hypothesis. You need not necessarily buy into it, but my belief is that many brands masquerade in the eyes of their customer because their behavior is episodic or transactional, as I would term it as. But truly endearing and enduring brands are those that follow the philosophy of lifetime value of a customer and consequently build and nurture lifetime engagement. Because no amount of multi-million-dollar advertising is going to get you greater share of wallet of an existing customer or new patrons than word of mouth. Okay. Sorry. Perhaps several of you have heard of the brand Lemon Tree. I want to quickly, before I move on to the slides, speak about who is behind brand Lemon Tree. There's a gentleman called Patanjali Keswani. The first name need not be confused with any relationship with, yes, we are practitioners of a different kind, but nonetheless. And IIM Calcutta, since I'm mentioning, you're all well-read and studied, so IIM Calcutta, IIT Delhi pass out, selected by Tata Administrative Services, served Indian hotels, Taj hotels, for 17 long years with distinction. In his quest for learning, he then got into this consulting space and worked for A.T. Kearney, the global consulting major. All along, he nurtured this dream of creating a value proposition in the hospitality space for the growing mid-market segment, both within domestic shores as well as in the global space. And therefore, Lemon Tree as an organization was incepted in 2002, and in 2004, ladies and gentlemen, a modest beginning in the form of a 49-room hotel came to be in Udyog Vihar in Gurgaon. That was circa 2004. 20 years later, with customer faith, stakeholder faith, 7 brands, 65 destinations, 10,500 hotel rooms, 108 hotels and batting, continuing to add 15 to 20 hotels every year. A listed company in 2018. Lemon Tree Premier, which operates between the 4 and 5 star, that's the common parlance used. Lemon Tree operates between 3 and 4 star. Our economy version is called Red Fox. In 2019, the organization had a desire to present itself in the affordable luxury space. And therefore, that's how Aurika was born. First in Udaipur, a 138 resort proposition in a lake city where all the prominent brands are around the lake or within the lake. This one is perched on a hillside. Aurika then traveled to Coorg, and our biggest contribution to Maximum City is Aurika, 4 kilometers away from the Sahar airport, 669 keys in one edifice, which makes it India's single largest hotel inventory in one place. I was almost envious. You know, I'm a salesman for life. So I wasn't going to give up on the opportunity to speak to you. Hopefully, we can have a little fight to try and see when your next summit is held and if I can pull that there. But nonetheless, our second, so whilst we grow in the mid-market segment, ladies and gentlemen, before I speak of our second differentiator, I provide a disclaimer. One is not evoking or attempting to evoke sympathy or empathy. But it is with great pride that one shares with you that 19% of our colleagues are those that I call Ishwar ke den ya Allah ke den. They are differently abled. They are opportunity deprived. If I was to quote a number, because the marketplace is dynamic, if we are 8,000 of us working, 19% of our colleagues are, as English language defines them, as specially abled. They work, they are speech impaired, they are hearing impaired, but you know what? This gentleman whose name I took, the founder, has enshrined in the constitution of our organization that this journey will continue forever. There is no... I must clarify, as consumers, subconsciously a concern may come up that, you know what, are any quarters expected to be given in terms of service expectation? Ladies and gentlemen, I hasten to clarify, none at all. They all work. We ensure, to the best of our ability, that identification of their abilities are channelized and watched over so that the ultimate paying guest experience is not compromised on. What is heartening for all of you to know is several of these colleagues of ours have been denied the opportunity because they have not been found able by others. They work in entertainment outlets, they work in front office, and they work in housekeeping too. So as I was being inducted into this organization, and by the way, I'm this organization's newest member, because you won't buy the fact that if I say that I'm the youngest member. My journey began on 2nd of April. I've served Oberoi Hotels for 19 years, Max for 6, 13 with ITC Limited, 4 with Sarovar, and my sales pitch worked with the founder, so I'm here. I oversee sales at this age for 108 hotels. So without going to Tirupati, I sort of dedicated my hair to the cause. So I was asked this question, Mr. Rai, do you look under the wash basin to see if it's been cleaned? I said, no. So you're absolutely right. But when the person then went on to tell me, he says, you know what, our colleagues in housekeeping will not go to their next item on their checklist without cleaning this. And it made me self-reflect, and it brought me down several notches to say, hey, you know what, Sanjay Rai, if you were in that place and said, hey, you know what, this happens every day, the same old routine, let me take a shortcut. And in a day and age, ladies and gentlemen, where certain leaders of the past who exemplified heritage, who honesty, they are evoked for different reasons. And we use this adjective, can I be very honest? Either you're honest, or there can't be something very about it. So, oh boy. So I am awfully sorry, I'm going to. So, I'm not going to read out this, please have a look. I'm conscious of the fact that I'm essentially, we have embedded ESG in our model. May I move to the next slide? Brilliant. At regular intervals, blokes like me are subjected to enhanced sensitization so that we can come up to the expectations of our special colleagues, because a large portion of them are those that who are hearing impaired. So let's talk about service excellence. Pre-pandemic, those patrons of Lemon Tree over the last 20 years or so were exposed to the DNA of Lemon Tree, which was fresh, fun, vibrant, and above all, spirited. Came the pandemic. Suddenly, the orientation of our service ethos underwent change. We were being directed by the government on largely the don'ts. And that led to, ladies and gentlemen, a disconnect between service expectation from the guest standpoint and our ability or the lack of ability to meet those expectations. And therefore, in the post-pandemic era, we had to revive our original service ethos and rediscover, hopefully, our original mojo. So that's been the journey that we are on. From the healthcare standpoint, what's been mentioned on this slide and the consequent slide, I dare say, would be applicable too. In terms of baseline, Manoj highlighted from the airline perspective, I just want to underscore one aspect again as a professional. There's a difference between stating on a piece of paper or in a training session or in a hiring session, humility. Because there are two types of humility, unfortunately. One is those of us who put on a cloak of humility, and those that are genuinely humble. Customers are able to, in our space, or for that matter in the healthcare space, or in the airline space, they are able to differentiate between a plasticine smile and genuine warmth. In healthcare, oh, doctor is on his way, please wait. That entity whose the patient is paying good money to come and see you. So these are things, even in hotels, we must guard against, sort of letting ROE, which is return on equity, be replaced by return on ego. So perhaps in service, you never arrive. In our space, you're only as good as your last guest experience. And therefore, you're only as good as last night's revenues. You must not appear to be profiteering. Very often, customers tell you, hey, you know what, you come to us for business when you need it. But the idea is to build that lifetime engagement and stay on course. I'll leave you to read this. This term, sense of belonging, which all of us aspire and strive to achieve, is what is most important. And in our organization, that is a reality because of what one stated earlier. The challenge for brands has always been, if stay is baseline, experience is second. You uplift yourself and strive to get to that stage. But finally, it is about creating memories. There are several notable examples across the globe and within India where customers have turned fans into fans. Fans will always stick by you through thick and thin. Okay, the business end, and I stress profit without profiteering. You may say, this guy is talking about his brand, etc., others exist, but, you'll allow me an opportunity to take leave of modesty. We operate in a competitive environment, but it's important for you to understand where we come from. So essentially, we straddle the entire spectrum, ranging from development to ownership to management of others' assets to owning the brand, loosely called as franchise. Out of our currently 108 operating hotels, 41 are owned by Lemon Tree. The majority of the others are managed assets, and a few, very few, are franchised. As you perhaps are aware, not many hotel companies own their own hotels. Therefore, the vision of the founder was that we will first own our own hotels and then demonstrate, having proven our ability to build a profitable business model, be available to others because they would be proof of performance. Our competitive advantage hinges on 3 platforms. One is location, location, location. We will not compromise on location. Cost. Frugality was a term used by Manoj. And it's true for all brands across categories. If you lose sight of that element, especially in a capital-intensive business, hotels are also capital-intensive. The question is, how do you smartly engineer your model to ensure profitability? We have a track record which is enviable of not having project overruns. And that is why our lending partners thus far have been satisfied with our performance. That has been our track record. From a profitability standpoint, let me give you some things to ponder over. Perhaps you're already aware, but nonetheless. Lemon Tree builds hotels at 60% of what it would cost to build a 5-star hotel. Consequently, the average yield would be half of a 5-star hotel. So if somebody charges you, say, 10,000 rupees, we would be at 50% of that. I'm talking of the room revenue. The overall revenue would be 60% of a 5-star hotel, because Lemon Tree's focus is essentially on the rooms, where profitability, as you run hospitals, you would know that the room profitability is where it actually sort of benefits the investor and the shareholder. In our case, it's close to 80%. Simply put, if we make 50 rupees, our cost is 25, which means our operating profit is 50%. A 5-star hotel would loosely be 35%. Perhaps you could just glance through this slide. I'm conscious of the time. Somebody put up his or her hand so I can move to the next slide. Yep. You okay? Thank you, sir. I've given you a perspective earlier, but from a return on capital employed, our ROS, as the term is construed, and I know there are finance notables in the audience, is 1.7 times higher than a five-star hotel. Just to give you an idea on how we manage our efforts on profitability, Aurika, Sky City, the hotel that I referred to, the one in Bombay, on 5th of October this year, will complete 1 year of operation. But, ladies and gentlemen, in its first month of operation, it broke even at an operating expense level. What does this mean? We ramp up on manpower depending on where the requirement so you have to be smart in terms of seeing how your business is developing. Heat, light, and power, which is a significant expense. Again, as several of you would be engaged in terms of bringing solar and renewable energy sources, our organization is no exception. Design of our hotels. Those that are owned by Lemon Tree, the profitability, EBITDA, would range in the area of about 50–55%. Managed assets are between 40 and 45, and the reason for that is we have not been involved in the design of those hotels. So this is what, and our founder who spent time with Taj Hotels in the luxury area and being an engineer, his acumen in these areas has led to where we are. Having said that, our journey continues, and I would request each one of you to give our brands an opportunity to serve your interests going forward. In conclusion, I'd like to wish each one of you good health and happiness in your personal space. Wish you a wonderful year ahead, and may you continue to achieve great heights in your professional endeavors. Thank you so much.
Thank you, Mr. Rai. Thank you so much. To present you with a token of appreciation, I'm going to call on stage somebody that you would recognize, an old friend and colleague, Dr. Vishnu Panigrahi, the Head of Medical Services and Operations at Fortis Healthcare.
"20 years back, this young man and this young man started Max Healthcare journey together in Saket.
Thank you so much, sir. Thank you. So we're going to have a shorter tea break today. Instead of the customary 30 minutes, we'll be allowed between 15 to 17 minutes. So please ensure that you make your way back. Just a quick announcement before you head out. The photographs for the events that have been taking place since yesterday will be available on the app. So in case you have not downloaded it, please do download it and check your profiles. Apparently, all your own pictures are available on your profile. So that's going to be really cool. So check that out. And oh, by the way, the entire set of pictures will be available 1 week from today. So no calling anyone saying, where are the pictures, where are the pictures? That's going to happen, don't worry. 17 minutes starts now. I'd request everyone to kindly find a seat for yourselves and settle down. We'd like to start now. So I see a few seats available here. There. There are about 5 or 7 seats available on this side for those of you looking to sit. All right. Welcome back, everyone. We are now entering the heart of our session, the panel discussion on new age healthcare operations. This is where innovation meets execution, and we've assembled a stellar lineup of experts to shed light on how we can optimize healthcare delivery. Joining us on this panel are Dr. Kelvin Chung, the CEO of Gleneagles Hospital, Kota Kinabalu, and Timberland Medical Center. With a visionary approach, he's redefining operational excellence in healthcare. May I invite you on stage? Mr. Anil Vinayak, Group Chief Operating Officer at Fortis Healthcare. With his keen strategic mind, Mr. Vinayak is known for turning challenges into opportunities for growth. Dr. Bishnu Panigrahi, Head of Medical Strategy and Operations at Fortis Healthcare. His ability to align clinical strategies with operational efficiency is unparalleled. Dr. Jatinder Arora, the Chief Operating Officer of the Bangalore cluster at Gleneagles Hospitals, India, whose operational insights are backed by a wealth of experience. And finally, we're privileged to have with us Mr. Mahipal Singh Bhanot, the Business Head NCR at Fortis Healthcare, moderating this discussion.
So a very warm good morning to everyone and to all the panelists for joining us today to discuss on the new age healthcare operations. Indian healthcare system is undergoing a profound transformation, challenging traditional paradigms and established norms. As of 2023, India's healthcare landscape is not only evolving, but also rapidly adapting to meet the demand of growing and diversifying population. With over 1.4 billion people, India faces the monumental task of ensuring quality healthcare across vast and varied geographical regions. Technology integration and patient centricity are at the heart of this transformation. According to the National Health Authority, digital health solutions have been pivotal in expanding access to healthcare services. The adoption of telemedicine platform, for instance, has surged by 120% over the last 5 years, reaching approximately 25 million patients in remote and underserved areas. Similarly, the launch of Ayushman Bharat Digital Mission has facilitated the creation of over 100 million health IDs, enabling more personalized and efficient care. The shift from traditional reactive healthcare model to a more proactive and preventive approach has also been significant. Primary health centers, which number around 1.5 lakh across the country, are increasingly incorporating technology-driven tools to enhance patient care. This shift has led to 15% reduction in hospital admission for preventable condition over the last decade. This is as per the data which is released by Ministry of Health and Family Welfare. Moreover, the digital revolution has spurred innovative healthcare delivery models. For instance, asset-light models such as mobile health clinics and virtual consultation platforms are gaining traction. The market for these digital solutions is projected to grow at a CAGR of 30% over the next 5 years, reflecting the increased demand for flexible and accessible healthcare options. So what is the need of the hour? As the healthcare scenario evolves, there is a pressing need to blend technology-driven new age healthcare delivery models with traditional models. This hybrid approach is crucial for creating to a patient-centric framework that addresses individual need while leveraging the strength of both modern and conventional practices. So the new age healthcare delivery models are not just about technology, but a paradigm shift in how healthcare is conceptualized, delivered, and experienced. At the core of this shift lies the recognition that healthcare is not a one-size-fits-all proposition. Individualized care, tailored to the specific needs and circumstances of each patient, is the cornerstone. Value-based healthcare framework incentivizes healthcare provider to focus on the quality of services rendered as against quantity. Under a value-based healthcare model, healthcare providers are compensated based upon patient health outcomes. They are rewarded for promoting healthy patient outcomes, reducing the chronic disease burden, and helping their patients live healthier, live through evidence-based medicine. So value-based healthcare are vital to a larger quality strategy to reform how healthcare is delivered and paid for. So my first question is to Mr. Anil Vinayak. So Mr. Vinayak, how will value-based healthcare get delivered across different geographies, rural and urban divide, and amongst different economic strata?
So, we heard Nachiket more in the morning. Right, so he's envisioned the future as far as India goes, right? When it comes to moving towards a universal healthcare model, how that will sort of happen. I don't want to go there because, he's the expert. There are a lot of policy people that are working in that direction. I just want to stick to a view of where we will fit in, right? As he also alluded to, what is it going to be our role in that journey as the country moves towards universal healthcare. And I think this is applicable in other markets which already have universal healthcare as well. So if you really look at the expectation of the community and the government, what is it? It's very simple. It is how do I deliver the longest possible independent life to my citizen at the lowest possible cost. Very simply put, right? I'm just not an economist. But very simply, you're trying to see at a population level, that's what the government wants. How do I make my population live longer, more independently, so they're productive and not dependent, at the lowest possible cost? Now, what does that mean from a consumer standpoint? When I look at my customer, what is he expecting, or he or she? Right? They're also expecting very similar, which is how do I live a long and independent life as an individual at the lowest possible cost to me? Right? Now, it doesn't matter who funds me or whatever, but how do I enjoy my life more? When you think about where we fit in that scheme of things, right, as consumers start to think that way, increasingly they are, then what does that mean? It means that we have no choice but to move to a more integrated model than we are currently in many markets. In India, for example, we are largely in episodic, tertiary, and quaternary care. We do a little bit of the other stuff, but very limited. And we are really not much present in the entire journey of the patient's health outcomes. So for us, I think the implications are, what can we do as a hospital that already exists in a certain way to, first of all, help our core communities stay out of hospital longer? And if they do have to come to me for whatever reasons, how do I get them back into the community fastest? Right? And finally, is there anything I can do after their recovery in their home setup? Right? So those are the three buckets of what really it will mean for us, right? What is our role in keeping people out of hospital? Is that our role at all? And people may challenge that and say, no, that's not my job. Yeah, but I think we don't have a choice. As the market moves, we have to move alongside, and the country is clearly moving in that direction. Most other places already are. So we will have to think about that, and the role of prevention, the role of immunization, screening, what can we do in that entire gamut of areas? Second, what do we mean by get you out faster, right? We always looked at ALOS as a turnover thing, that we are able to turn over our beds faster. But the reality is that the patient is not there by choice. They want to get out as fast as they can as well. And unfortunately, our systems, are they really geared towards that? Right? Are our incentive models geared towards that? Are our own incentives? How long does it take for the doctor to see the patient the first time and prescribe a bunch of tests, right, and a preliminary medication? How long does that report take to come in? And then how fast can we start the treatment? I don't think these are metrics that today we have in many places. So I think the implication of all this to me is, the one, we have to integrate better with the environment and the community. Two, we have to start thinking and evolving ourselves, not just in the area of outcomes. I think we've done some work on outcomes, right? We do know some outcomes. I think we need a far deeper understanding of what are the health metrics that are important for the customer or the patient. And am I in a position to have the data today in my environment and be able to understand how I'm performing against that? How do I align the entire clinical community in terms of those kind of directions, right? And how do I manage our own incentive structure, which today is geared towards hospital stay rather than outside? The other aspect, of course, is technology, and I think there we do a very good job. We are early adopters of technology, so we do everything possible to get the robo in and faster recovery and all of that. But do we really? Are our processes designed around that? I don't think so, because if you think about it, a robotic surgery case ideally should go home in a couple of days. But in our setup, the patient comes, admission takes its own time, the whole process is not geared towards getting you out as fast as we can. So that's where the process efficiency comes in. And I think the last piece is around the patient empowerment. How do I involve them better? Today we are a little bit patronizing of our patients. Right? We say, oh, we know better. But I think we need to be able to involve them much better in the journey of their own care, because nobody cares about their health more than them, and certainly not us. So we shouldn't presume to think that we are the experts in that. So I think it's a journey that really is, in some ways, starting up in India as this whole thought process is going on. And where we find our place in this will drive our long-term success, in my view.
Very rightly put, Mr. Vinayak. Building on to this, my next question is to Dr. Panigrahi. So what is the kind of sectoral reforms which are required to give a boost to healthcare system and processes in India?
See, if you look back at since independence, pre-independence, more than 60% of our deaths were from communicable diseases. Yeah. Now it is non-communicable. And the NCDs are increasing, so we know what is the workload that. And the way things are evolving, so see, the purpose of meeting and strategizing for the future, we have to look at the future also. So what I'm looking at is that hospitals will be taking care of acute care. In other words, the surgeries, admission to ICUs, cath labs, endoscopies, daycare, dialysis. So all this. And there's a lot of movement which will happen. Hospitals will go into the homes. In other words, what I'm saying that we take care of the acute care and then go back to the homes. So that process we have not yet cracked. So for that, the workforce, that needs to be sort of trained, aligned to the needs that you think that they need to deliver if the patient has to go home early and take, because the NCD disease burden is increasing day by day. They are going to have lifelong follow-up a patient may have come for a bypass surgery or a knee replacement, is a diabetic, lifelong you have to take care of, because not only the diabetes, is his kidneys okay, is his vascularity okay, so how do you take care of that? So, because as Anil rightly mentioned, healthcare has become so episodic, but they come, we treat them, then bye-bye. But we are not looking at a long-term thing, so that longitudinal tracking of patients have to be there. So to answer your question directly is that the process have to be aligned to that. So one is in the hospital, how do we see that all the people taking care of the acute care, the doctors, nurses, and most important, I think, so which we keep ignoring is the nursing staff who should be positioned at the right place, should have the right skills, not a head count being put there, and the paramedical staff, because that is a lot of work. In the morning session we discussed also. So are we credentialing them, privileging them properly, doing the in-house training for them, and so that the right person is at the right side of the patient. And the other part, as I was mentioning, once they leave the hospital, we should create a workforce to take care of them. The other thing I wanted to just put across is that, see, we have to also look at what we can do for the country. We always expect the government to do everything. But as John F. Kennedy had said, what I can do for the nation, we should be looking at. So now with the internship, that scheme that has been rolled out, so we should think amongst ourselves, so what are the training programs we can do to have these interns? So whether it's for a dialysis technician, for a daycare, for a phlebotomist, whatever it is. So we create a curriculum for that, so that we work on that and look at having them onboarded. So after that internship is over, because they are being paid by the government, and whether we pay normally or what, that's something that we can look at. But most of the burden will be taken care from this internship that the government is going to give. So they become a workforce trained to deliver care. Whether they work within your setup or they go outside, that is immaterial. But at least you have a trained workforce who will be there to take care of patients.
Very rightly said, sir. So healthcare delivery is poised to be as much out of the hospital as within the hospitals. So new models of healthcare, such as doctors at home, healthcare at home, post-operative care at home, and rehabilitation after surgery at home are significantly reducing length of hospital stay and benefiting both hospitals and patients. So the redefined value chain embodies a holistic approach, prioritizing wellness, continuity, and patient empowerment at every juncture of the healthcare journey, shifting focus from illness to wellness, treatment to prevention, and self-care. These models are particularly beneficial for India's aging population and those with chronic conditions, offering personalized care in the comfort of their home. As the healthcare landscape evolves, home healthcare will play a crucial role in ensuring accessible, efficient, and cost-effective medical care across the country. So for the healthcare models to be efficient and create an impact, adoption of digital technology and data-driven medical approach is a must. We all have witnessed patients consulting doctors over call on a mobile phone and a government app helping vaccinate more than 2 billion people during a global pandemic. AI-driven analytics, smartwatches checking vitals to highlight a potential medical condition, robots performing medical procedure over 5G network, genomics are the new realities in the foreseeable future. New technology will also alter consumer expectations. There is a noticeable shift towards healthcare services, mirroring the convenience and accessibility offered by e-commerce platforms like Amazon and Flipkart. So a doctor, hospital, and laboratory in your pocket will no longer be a science fiction. The adoption of new technology has massively transformed Indian healthcare space in the past few decades, with the pandemic further accelerating the trend. But what will the space look like in 2047 when India completes 100 years of independence? While it is difficult to predict, but there are several models there are emerging models that can be spotted. So my next question is to Dr. Jitendra. Dr. Jitendra, how will healthcare get transformed with digital technology and data-driven care?
Thank you for the question. Before answering this question, I just want to share one statistics of the country. We are having a population of close to 1.5 billion, and close to 1.2 billion people are using the mobile phone. So can have a look at the adoption of the technology. And out of this 1.2 billion population, 1.05 billion are using the data through mobiles. So internet usage. And it is easier to adopt the new technologies, when you are already having some basic things in your hand. If you look at the history of healthcare, the evolution in healthcare is mainly driven by healthcare innovations, innovative business models. You have just mentioned about EMR and telemedicine. When we were graduating from the colleges, we were mentioning everything on the paper, and there were glass syringes to take the samples. I guess the senior clinicians can very well correlate with that. And then the vacuum had come. They were barcoded. The chances of errors were less. And EMR, the patient used to carry the bulky files with them. And it was difficult for doctor to mention the comprehensive history. Now with EMR, you have everything in place. Patient is also having an app in their mobile. He is also aware what is my problem, what is the outcome, what are the chances of my survival, how the doctor is going to treat them, all the past history. So, people are also well aware of their problems. There are certain areas in EMR which has, added to efficiency in healthcare. One of the areas which I have witnessed myself, when doctors prescribes in the OP pharmacy on the EMR, it gets reflected, when doctor prescribes to a patient, it gets reflected in the OP pharmacy. It ensures the sale of pharmacy. The patient goes directly there. You have a queue management system there. On his token number, the patient goes and buys the medicine. It ensures also you are prescribing the medicine from your formulary. So I'm just telling you the digital, technology, how it is helping in efficiency and all. Another important thing which we have observed in our professional career, there are multiple steps in prescription. When doctor writes a prescription on the order sheet, it is transcribed by a nurses on the drug chart. Then it is indented by a nurse on the system. These all two steps have been eliminated when doctors writes an order directly on the EMR. So there are two steps which got eliminated, and there are two errors also which are getting eliminated. Transcription errors are going down. So it ensures the patient safety. All the the innovations are designed around patient centricity. Patient is in the center, and adding to how they are adding to the efficiency. So during COVID time, when we go and see how does such a huge country we were able to contain this disease, with the lesser mortality as compared to other nations, I guess teleconsultation played a big role. And if we go by the data of government, close to 80 million people have taken the teleconsultation. And e-Sanjeevani is a very famous app which is being still utilized by government till today. So non-COVID and COVID time also we are utilizing this. Even in the corporate hospitals, there is a teleconsultation department where the payment gateway is also there. You can charge for your consultation, and it adds to the revenue also. It is like helping the patients who are not able to travel from the remote areas, and still, through digital technology, they are availing the medical treatment. In the coming time, what I feel, the more patients will be coming through digital innovation, digital channels, like they will be seeing, how to reach at a hospital through digital channel rather than direct patients who are coming there. So you will see that trend, and more patients will be availing treatment through teleconsultation than coming to hospital. So there will be equal crowd which is availing treatment through teleconsultation. Then, there are certain areas which are considered to be stigma for a patient to go. Like I'm sharing an example of psychiatric patients. Government has come up with a Manas app where, without revealing your own problem to the public, it's one-to-one interaction with the doctor and the patient. You can produce more resilient and, healthy society, which is mentally fit. So, so many things are happening in this area. I myself was working in Fortis Escorts Hospital, Dehradun, which was managed through EICU. We were not getting the experts who could manage our post-operative patient, post-bypass surgery, post-PTCA. So we were managing with a very thin manpower with us. But with the command center, and the doctors available in a Scott's hospital who were kind of managing our ICU through a remote location, higher resolution cameras were put in our ICU, and each and every patient was monitored, and we were able to build a very good ecosystem, in a smaller town. So there are so many things which have revolutionized the healthcare in the past also, and it's a continuous journey. We look at robotic surgeries. The stay is less, the tissue scarring is less, the incisions are small. So I guess the technology is helping a lot to the healthcare, and in the coming time also, by 2047, as you just mentioned, maybe the scenario will be entirely different. You will have only tertiary and quaternary care patients in the hospital, and primary care will be given at the home only. And the post-operative wellness, those things will also be managed through very well managed system. Thank you.
Thank you. So NABH has just released the first edition of digital standards for healthcare just a week back. India, with such a vast population, has so much of health interface with the patients. However, we do not have a unified data. We still rely on the Western data for our analysis and for research purpose. The data in Indian context is very, very fragmented. It is not put to use, and we do not do an analysis on that. So do we see that trend changing, Mr. Vinayak, in how will this transformation happen, and how will that benefit the patients and communities at large?
Certainly that will happen. So I think the NABH guidelines are a very good step in that direction. And if you read why they're doing it and what the purpose is, I think the first, they're aiming to digitize or at least set some standards for all the smaller EMR manufacturers that are serving the thousands and thousands of smaller hospitals and nursing homes across the country. So if you have a common standard, at least then all of those EMRs are going to be able to be interfaced. The larger companies, I think it's much easier for us to interface our EMRs because we're already relatively tech savvy and we have those teams to be able to build that. And I think that integration will also be possible once this basic framework comes about. I think this is inevitable. It is going to start slowly and then suddenly, just like on the first day in the plenary session we heard from Microsoft, that it will all be very gradual for a while and we'll think nothing much is moving, and then suddenly we'll find that all data in this country is digitized. Similar things happened, if you recall, around income tax, for example. Yeah. It just takes a few years and then it's suddenly there. And my sense is that's what will happen with digital data as well. So we should be part of that journey as all of our hospital groups, of course. And we should encourage our community as well to participate.
So artificial intelligence, machine learning and genomics, they are also coming in a big way in healthcare industry. So Dr. Kelvin, in Hong Kong and Malaysia, do you see what is the adoption and how is that actually changing the healthcare landscape? Artificial intelligence and machine learning and genomics.
Right. So with regards to AI, I think this is something no longer new for us. With the advancement of technology, I think it has progressed by leaps and bounds. Now you see even handphones having AI functions and all that. So we do have AI integrated in our healthcare systems as well. I mean, when you look at echocardiogram and look at angiography and all that, there's so many options available these days. And in fact, it is very useful. And another example would be with regards to diagnostic imaging, where AI is also involved to assist the radiologists to actually better interpret. Because sometimes we all know that in medicine, it is very much operator dependent and it's dependent on human beings well. And human beings do make mistakes, right? Just now, during one sharing session, I heard that 99.99% is not good enough. So we need to be 100% sure that that means basically zero margin for error. So with advancement of technology, AI coming in, then this will definitely provide better support, right, to us, and then hopefully we can achieve that 100% consistently.
Perfect. So healthcare tomorrow will be essentially P4 medicine. It's preventive, personalized, participatory, and predictive. Emphasis will be on maintaining good health. Telehealth will ensure that distance will become meaningless and geography becomes history. Healthcare will be personalized, real-time, evidence-based service. Artificial intelligence, machine learning, robotic surgery, molecular genetics, immunotherapy, gene mapping, and personalized care are the sum of the transformative innovation that's going to happen in the healthcare space. So the understanding the healthcare of future will no longer be a doctor's domain. Heavy reliance on software, coding algorithm means engineers too will become part of care management modalities. The demand for healthcare workers in India is undergoing significant changes driven by population growth, technological advancements, and evolving healthcare need. And we must bridge the current healthcare workforce gap and prepare for future demands in expanding healthcare value chain. And new healthcare models will require advanced skill set and workforce. So while you touched briefly, Dr. Panigrahi, on the topic of how nursing and the paramedical needs to be trained, but healthcare is a service and which will always be delivered by people. And how is the healthcare workforce in India evolving? What are the challenges? Because we have heard that there is an acute shortage of nursing in the paramedical staff. It existed 2 decades back. It exists today, and we don't in the foreseeable future that gap will be addressed. So how will that essentially will be able to bridge the gap? Are there new alternate models and new cadres which are emerging in healthcare space?
If you look back at 2015, all the member nations of the United Nations, they signed up and agreed on a sustainable goal roadmap by 2030. And they had multiple things, and one of them was on the healthcare part, also healthcare workforce. So how do you look at One Health? Because across the globe, this is a challenge, and India is no exception, and we being a nearly 1.5 billion population, this is going to hit us. So we have to be prepared for this. So healthcare, if you look at all the indices, whether the doctor population ratio of doctors, dental surgeons, nurses, the only place where we are slightly near to the developed world thing is the pharmacist. It's very strange. All the others we are way, way below. So obviously we have to sort of upscale this. And how we can't sit idle. So we have to enhance our training programs and see that, because if you look at most of the medical colleges, because I've been a teacher for 10 years, and then before I came here, and then I worked to have a close association with the medical college. The training is more to doctors and nurses. You hardly find the others being trained. Whether you look at the dialysis technician, the OT technician. If you look at any OT technician, they go to some place, they get a certificate, and then we take them. So the main thing is that, see, any patient who walks into the hospital, all of us have to be absolutely 100% sure that any person, any of the healthcare workforce touching that patient, coming in touch with the patient, should have the skill sets to manage that patient. So keeping that in mind, we have to start working on how do we have training programs. So we can't solve the problems of the entire country, but as major healthcare providers, we have to sort of start looking at, like we have the NEBH for different specialties. So whether OT technician training, dialysis technician training, your daycare chemo, that happens. And from the nursing part also, all the subspecialties of nursing, how do we look at it? And there's another thing about the nurse practitioner that's coming in also. That's something that we have to look at. And now when you look at the NCD burden, see, as I said earlier, that and Anil just alluded to about the screening part, there's a lot of work that has to happen outside the hospital. And so the credentialing of these people, whether it's a radiology technician, whether it is the dialysis technicians, the courses have to be structured, we have to vet it, see that the right persons are there. And then for the screening programs, a lot of modalities are coming in. But I think so the regulatory things are also taking a pushback there. In the morning, the butterfly thing was alluded to. it's a very nice handheld model to do screening. And in India now, amongst females, the largest cancer that is staring is cancer breast. So, and early screening is required. And for that, where it has got stuck is that because of that PCD-NDT thing, so getting all the clearances done. So if you look at the Western world, for example, now, whether it's the cath lab technician, the NIC, the technician, or the radiologist, they can do the scanning, the screening, that ultrasound that happens, or the cardiac echo that happens in a structured format that is there. And the doctor, whether it's the cardiologist or the radiologist, they see it and then give the report. Here, the technician cannot do that. So I think so, if you have to take the leapfrog to the next level, we don't have so many cardiologists, so many radiologists to do the screenings, to look at that. So some changes have to happen as far as regulation is concerned. We as an organization and from the healthcare sector, is something that I don't have an answer, but these are things that we have to look at. So speaking specifically, what we can do is that I think so, and a take-home message is for me is that all the other specialties, whether it's from the nursing example, all the things that they touch upon, their training has to be sort of customized, that the patients that they're handling, they're able to take. So that structured training happens, they are evaluated, and retraining, so the skilling that happens. So a technician being put up in the dialysis thing, again, that structured training that we have to see that they have that, and see that they're privileged there, and keep ensuring. So I think this is something that we have to do, because we cannot afford to have any patient coming in not being handled properly.
Yeah, completely agree. So while, healthcare is getting transformed and a lot of digital solutions are getting implemented, EMR is one of the big things, and a lot of other artificial intelligence and machine learning coming in a big way. So the healthcare manpower also has to be actually suitably trained. So question to Mr. Vinayak on the digital literacy of our healthcare workforce. How will this gap get addressed?
I think we overestimate that problem. You design a good app, and today you see, a few 100 million people adopt it, and nobody goes and teaches them. So I think the country is quite digitally literate. Today morning in the walk, the best example of digital India that struck me in the face, I was walking past, and there's a best bus stand where they have mobile charging points, right, available in a bus stand down the road. That's an example of how penetrated mobiles are, that anybody and everybody, they may not have access to a charging point, but they have a mobile phone. And because they have a mobile, they're educating themselves all the time. So I think we overestimate that challenge. What the challenge is designing the right process, protocol, and simplifying it, putting it online and empowering people with it, and they will adopt it. That is the last of our concerns in my view, including our workforce and including doctors. Doctors don't like EMR because the EMR interface sucks. Let's be real. Right? Tomorrow, if it was intuitive, it was voice-enabled, ambient, I have my communication with my doctor, with my patient, and it just captures everything and gives me imagine which doctor would not want to use it. I don't know. Right? And we saw something yesterday in the Practo session for, the Practo AI shared something that they're working on. There are others as well. Ognito we have tested. It is extremely, it looks pretty promising. So if we have technology of that nature, then we don't have a problem in digital education.
Very rightly said. So I think the transformation will be similar to what the banking reforms has happened over the last 3 decades, where probably we don't visit now even an ATM. Now I think the similar transformation, what we are looking at, is going to happen in the healthcare space as well. And we heard our speakers from aviation industry, from service industry, and also Dr. Nachiket. The kind of, how does the rule of aviation or the hospitality rules industry will apply to healthcare? And rules of, principles of many industries, they apply to healthcare, which itself is a very, very complex operation. Like, take an example, supply chain matches the retail industry. The workforce varies in a healthcare setting from a highly skilled to unskilled. IT and communication has a major role to play. Besides like hotels and airline, healthcare too is a service industry, and it is about consistency and uniformity of delivery. And healthcare will continue to get delivered through people, and therefore no matter what the future workforce looks like, the essential of service excellence will remain the same. So the right service in the right time and uniformly accessible and predictable services is the key. So when you treat patient as a unique person, you can build trust and exceed expectation for consumers you would want to reach. An organization that lead with empathy and human understanding will always be in the forefront. A strong reputation sets a facility apart from its competitors. So my next question is to Dr. Kelvin. So Dr. Kelvin, a patient experience with healthcare determines its success. And with technological advancements, human contact is becoming less. And how will we retain culture of service excellence when we are moving away from very high contact service to low contact service?
One thing, okay, so we are all here, I think most of us in this room are in the service industry, right? So the first question we would like to ask is that, what is service excellence, right? So are we able to answer this question? So to put it in very simple terms, service excellence to me, it means providing service which consistently meets or exceeds the patient or customer's expectation. So I think that's very important, right? So it's not good enough simply just to meet it, but we should try and exceed their expectation. So it's very customer focused. Now, talking about that, okay, so back to healthcare, right? We talk about high contact or high touch service. So up till today, I think healthcare is still very much a high contact service. And of course, with technological advancement, as mentioned just now, some of the processes we are able to actually make it lesser contact, and that one is predominantly, I feel, more related to digitalization, which actually makes it more simpler, right? So, for instance, okay, so when we are talking about transitioning, right, moving from high contact to low contact, so we need to think about this question first, right? Why? Why are we moving? Right? Why not stay back at high contact? So this point we need to ask. So question number one, why are we moving to low contact? And number two, we should ask ourselves, right, did the patient want it? Right? Was it requested by the patient? Or is it simply the fact because we feel that technology has advanced and then we are trying to prescribe it to the patient? So these 2 points I think is very important. So let me quote an example. We talk about healthcare service digitalization, right? So with regards now, we talk about we have all sorts of mobile apps in our phone, right? One example, maybe you could have heard of this app called My Health 360, which is available in IHH Singapore and also Malaysia, right? So the app allows, there's a variety of functions, basically allowing patients to book appointments at home via the app, you know, checking on their medical results and all that. So making payments online and all that. So this basically eliminates contact, right? So previously you have to go to the clinic, make an appointment, or go to the counter and pay, right? So now you don't have to do that anymore. So in this point, right, so from this aspect, low contact, is it good, right? So it is actually very good because you ask the question, did the patient request for it? So I think most of us in this room, we would prefer that instead of having to queue up at the counter, waiting, you know, for minutes and hours, you know, to be served. So this is very important. So if the patient asks for it and we are able to deliver that, then I think that's value added and it enhances the patient experience. So in this aspect, lesser contact is good, right? Okay, so from that example, I think ultimately we need to look at it as, are we meeting or exceeding patient expectations? Irregardless of whether it is high contact, low contact, doesn't matter. As long as we can enhance the customer experience, the patient experience, that's the best solution. Okay? Right, so now then let me draw you to another part, right? So now we were talking about high contact and low contact. But then the question is, which is better? Right? So how do we determine, should we stay with high contact or should we transition to low contact? So this is very simple. I think usually we will just go back to the patient, right? So nowadays we rely a lot on patient feedback, and then it can be done digitally. So we have real-time patient feedback system. We have even retrospective online questionnaires that we send via WhatsApp or SMS to our patients. And from there we can get their feedback. We know what are the areas to improve. We know that what are their recommendations. would they prefer high contact? Would they prefer low contact? So it's simple. So the answer is all there. It's very data driven. And if we were to follow what they recommend, I think it wouldn't go wrong. Right?
So for a normal person, see, when you come to a hospital, it's a very, very, you are anxious. It's a very, unfamiliar environment. And you're going through a lot of emotions in your head. And when we look at the aviation sector, they look at courtesy and turnaround times. In healthcare, it is more about compassion and patience. So empathy. So Mr. Vinayak, what are the service standards that we need to look at, given that the low contacts will be there, yet we retain that culture of service excellence in the healthcare space?
Back to something that was said earlier, which is if somehow we could treat every patient like a relative, right? Someone I know used to call it the family test. If this was my family member, would I do exactly the same things? I think if we can somehow imbibe that kind of standard in everybody in healthcare, that would take us very, very far in terms of understanding, are we really doing what is necessary and right? So I think that's the biggest from my perspective. Now, how do you do that? Unfortunately, what happens is that when you apply a standard and you say that this is how I want you to treat the customer, then you've got to also introspect and say, am I treated that way? Right? Because that's certainly the question that our employees then going to think about. And therefore, we have to build that culture of togetherness, belonging, a sense of pride, a sense of ownership. And I think Lemon Tree, Sanjay presented that example of not just doing ESG for the sake of it, but really making that differently abled or specially abled people feel part of the whole community. And that brings things to life, right? When you do things like that, it really translates into reality. So I think those are the kinds of things I would say. Do we treat each other like family members? And then are we treating our patients like family? And if we can build a culture that sort of puts that together, that this is going to be the best healthcare organization in the world, without doubt.
Wonderful. So then, yes, please.
When we were hearing to these talks on health, hotel, hospitality industry and airline, the mindset is different. When the people go there, they are in a different mindset. When we are in hospital, the people are in pain, agony. Their aim of visiting is different in both the industries. So we have to have empathy and that kind of mindset where you put yourself in their shoe and see, what is to be given to them. So people are ready to spend on their vacations in hotels, but they are not ready to spend on health. So we have to see that part also. We are dealing with the patients, not with the, tourists. So that's important.
Absolutely. So the accessibility, quality, and the cost of the factors that we need to address. And to sum it up, in the, whatever new age, new healthcare operations, and all the new models operating, I refer back to the comment that Mr. Anurag Yadav made yesterday, is that in everything that we have to put care back into healthcare. I think that is very, very vital and very, very important. So thank you to all the esteemed panelists. It has been a very, very engaging session. Thank you very much. And although we have exceeded our time, if there are any questions, we'll be more than happy to take.
I seem to have developed a reputation, but yeah.
I'll take your time. I request everyone to read the Bohr Committee report, which was made in 1946. If anyone was working in healthcare in India, please read it. It is a Bible. It details out everything. If you would have done that properly, we wouldn't be discussing a lot of things today.
Okay, may I please invite on stage Mr. Ashish Bhatia, the Executive Vice President Operations at Fortis Healthcare, to present our panelists and moderator with token.
Public health. Right.
We'll have one group picture as well, please.
Right, sir. Sir, we have to move right. Thank you. Thank you.
Thank you so much. All right. Our next speaker, Dr. Pavan Agarwal, the authorized presenter for the Mumbai Dabbawalas, will take us through how this legendary lunch delivery system has achieved the extraordinary operational efficiency without relying on AI or high-tech solutions. It's a classic case of less is more and shows that sometimes simplicity can yield remarkable results. I think this is a session Miss Elizabeth Hahn had referred to this yesterday, so I hope she's here and she's able to listen in. Please welcome Dr. Pavan Agarwal onto the stage.
Morning, you all. Good afternoon. It was in the morning, now it is afternoon. Thank you. Inviting me on this dais. Learned people, doctor, and rightly she told about Dabbawalas. And I saw 30 minutes given to me. 100% I will finish before that. But friends, believe me, when I'll speak 30 minutes, 100% you will love to listen and nobody will move from chair. It's my guarantee. It's my guarantee. And not because I'm a good speaker. Yes, I'm a good speaker, but my contents are very good. And when she told about Dabbawala, I'll not tell the story of Dabbawala. I'm not a storyteller. I will connect their work with your work. And last 1.5 hours I'm listening to you all speakers. Really extraordinarily. And when I ask how many people know about Dabbawala, I think many of you must be knowing about Dabbawala. But I know what you know. You know they deliver lunchbox in Mumbai. They always on time and they never make mistakes. Friend, I will tell you more insight of this. As far as is concerned, let me tell you. Can you take out? I don't need. Friends, these people are not caterers. So what they do, they collect your lunchbox in the morning from your home and they deliver before lunchtime in office. After lunch is over, they will get back empty tiffin same day evening at home. That's it. It means they are doing simple 2 deliveries in a day, and on this 2 delivery, I speak globally. Just imagine. Sir, because their delivery is important, but more than that, how they deliver, that is more important. Many of your speakers were telling, yes, customer service, these all things, but sir, your delivery, how you deliver is important. So I am speaking, you are listening. What I speak, what you listen is important, but equally important, how I speak, how you listen. It's important, friends. And believe me, friend, as far as, because some other country people also are here, let me tell you, friend, what Dabba means lunch box. And the Wala means the man who deliver. So it's simply their delivery boys. Now the question arises, why Dabbawala need to collect your lunch box? Why you cannot carry your own lunch box in Mumbai? Mainly 2 reasons. Number 1, sorry, I will not wait for clap because my minutes are very less. So, mainly 2 reasons why you need Dabbawala to collect. Number 1, our customer travel by local train. And you know, Mumbai local train is overcrowded. So it's very difficult for Mumbai people to travel with empty hands. Carrying tiffin out of question you cannot carry. Number 2, long railway route, 60-70 kilometers. Sir, it takes 3 hours normal Mumbaiites to travel from home to workplace. So suppose you want to reach office 9 o'clock. You will start morning 6 o'clock. And still you want to carry your own lunch box. Your wife should cook 5 o'clock.
Bhatia sahab, Mumbai husband don't want my wife should cook 5 o'clock because Mumbai husband love his wife. Every Indian husband love, अंदर की बात कुछ और है, but husband love his wife. So he want my wife should go 8 o'clock. So what happened? Husband start 6 o'clock, wife cook 8 o'clock, and 9 o'clock who come to collect tiffin. Sir, my first message, we give service to customer, but we make customer's wife happy, that's a business. My what is message, friends? Really, friend, I'm quite emotional, I know that, but I will not have more emotions today because doctors are there. Friend, my message is this: when you give services, your customer should satisfied, but should deal it to other also. So when you give treatment to one patient, one person, believe me, the whole family gets happy. Am I right? It's a fact. It's a fact. The health care is the most important. बोलते हैं ना हम लोग जीवन दाता नहीं है, हम अन्नदाता है. जीवन दाता तो आप है. You are giving a life, really friend, safeties to peoples. And of course, मैं मुंबई में प्रचार करूंगा कि जो बीवी से करे प्यार, वो डब्बा वाला को कैसे करे इनकार. Let डब्बा वाला to collect your tiffin. Anyway, friends, as far as tiffins are concerned, I'll tell you, friend, what we know. We call ourselves as the Mumbai's masters of logistics supply chain. So, despite the fact, Dabawala don't know what is logistics, what is supply chain. Despite they are the masters. I don't know where is Dr. Harish is there. Wherever you are, sir. Passionately invited me, and I met Dr. Narayani when I went to hospital also for this session. And sir, before inviting, corporate people, learned people don't invite easily. What Dabawala, what Dr. Pawan, what he will speak. I remember one time someone wanted to invite me and he asked, what are the takeaway you will have in session? My whole education in Marathi is up. So Sanjay ji, I don't understood what you want to ask. I replied to the mail, said I don't know the takeaway. I will give away whatever you want to take away, take away. Sorry, not like this, not like this. Then among them, really, I'm not just taking name, but when Mr. Sanjay told that Oberoi, sir, more than 50, 60 sessions I have given to your Oberoi people. So he told me, Dr. Popo, don't say like this. In your session, these are the takeaways. Now from that day, friend, really, I'm not from medical. I'm a PhD doctor. But I believe everyone who comes here, he or she want to give away. It is up to you what you can take away. In 40 minutes, 30 minutes, I speak about passion, commitment, consistency. Sir, Mumbai Dabawala delivering line box in Mumbai last 134 years. 134 years. So that too with 100% execution. Sir, it never happened in 134 years, single tiffin not delivered. Impossible. 100%, 100%. I remember Dr. Kelvin was talking about why 99, 99, 100. So we are 100. I told Dabawala, yes. Sir, when I told Dabawala, suppose one tiffin not deliver, what will happen? Customer can eat outside food. You know what Dabawala replied? Sir, if one tiffin not deliver, customer can eat outside food. But suppose that day, my customer's wife put medicine for husband in the morning. And if that day I not delivered, and if something happened wrong because my customer, who is responsible? Dabawala says, I am responsible. I am responsible. So what is this? Sir, tomorrow doctor says, no, this is my first mistake. Sir, your first mistake, but that patient last breath. Uski aakhiri jaan hai yaar. Sir, matter is what? Execution, and that too, sir, accuracy. Despite Dabawala illiterate, it never happened single tiffin wrongly delivered. Impossible, impossible. When I told Dabawala, I speak in session, you never do mistake. You know what he replied? Dr. Pawan, we want to deliver our customer his own wife cook food, not someone else's wife. सब बोलते ना हमारे हिंदी में जिसके भाव सच्चे होते हैं उसके सारे काम अच्छे होते हैं. Sir, you must have feelings. And believe me friend, this is because of dedication, and that too in time. Our slogan, in time, on time, all the time, not sometime. You know why? So this is because of complete customer satisfaction. Our two main principles, work is worship, customer is God. So imagine how they feel, and you will find every time it happens, started 1890. So in 1890, one Dabala, one customer. Today, 5,000 people delivering every day 200,000 lunch box. 200,000. Sir, 200,000 tiffin by 5,000 people. It means one man carrying approximately 40 lunch box. Sir, 40 lunch box, outside container, inside container, food, basket. Total 40 lunch box. Weight comes to 50 kg, Pratik ji. 50 kg. And that too overcrowded local train, long railway route. Before 100 years, they were carrying on head. Today also carrying on head, because work culture do not allow any other system. They are doing consistently, doing friend, consistently. And that too by working 8 to 9 hours. I will show one slide when they work 9 hours, how these people consistently working for 9 hours. So you must be knowing, in our Mumbai, we have 3 trains. Mono train, metro train, local train. But Dabbawala allowed to travel by local train only, because they are allowed to travel by luggage compartment. Mono train, metro train, sir, don't have luggage compartment. I will show you how in local train, one person starting from here till end, how he deliver and how he come back. It will take 1 minute, but please try to understand. Really friend, you will find really it's amazing. Simple thing, but they are doing. I will start, and you assume all 5,000 people working more or less same. So this man will start from here. He will collect 40 lunch box of 40 different customers working all over Mumbai. One person cannot deliver. So what he will do? He will bring 40 lunch box and drop at the nearest station called Ville Barley. At this station, more 10, 20, 40 Dabbala will come, and tiffins are resorted. After resorting, he will ask to carry 40 lunch box, Ville Barley to Dadar. Again at Dadar, he will get down. Again tiffin resorting, he will ask to carry from Dadar to Grant Road. Again same, he will ask to carry Grant Road to Churchgate. He will drop at Churchgate. Oh my God. What normal people believe? Dabbala collect tiffin, deliver tiffin. No man. Throughout the day, double line, collection, delivery, loading, unloading, coding, decoding, sorting, resorting, overcrowded train. Sir is doing consistently. Now he will go by road from Churchgate to Nariman Point. It's a business center. Now last job, he will want to deliver in this express tower, maybe 40 hospital building is there. He will deliver 40 customers, 40 doctors waiting for lunch box. He will deliver in 20 minutes. Time with his own lunch. So you know how Dabbawala carries his own lunch? In one pocket, ma'am, lunch, other pocket, water bottle. Because he cannot add one more in 40. To make customer convenient, he lives simple life. Because of customer. So from the, I think, starting, we are always talking customer, customer, customer. So they are working. In 20 minutes he will come back. Now how he went in the morning, he will come same route in the afternoon. Empty tiffin. He will come, then, when he comes evening 5 o'clock, he will receive his morning 40, now empty tiffin, which he did at home 6 o'clock, free. My dear friends, starting morning 8 o'clock, 9 o'clock, till evening 6 o'clock, did he relax 5 minutes? So despite, you will find it's a life story. You can go and check. Every day evening, you will find happiest moment on his face. What purpose? Today job I had done successfully, I am happy. He will never say, today lot of pressure. Sir, बंदा क्या बोलता है? Hey, pressure किसको आता है? जो काम करता है. जो नहीं करता उसको नहीं आता है. So we are working people, pressure always are there. You are a doctor, I am a speaker. So we always have pressure. Despite I'm not saying I'm very expert. Last 25 I'm speaking. Before that, 15 I was a teacher. So 40 years I'm speaking, despite we have pressure. So really, as for working at Dabbawala is concerned, you must be knowing error rate. 1 error in 16 million transactions. And sir, who told this? Forbes. Forbes told. When Forbes told long back, they told okay, because they were not knowing what is error, what is million. They told okay. When someone told what is error, what is million, they returned one mail to Forbes, hey Nikhil, ek bhi galti nahi hai. Our dialogue is what? Error is horror. Don't look to mirror, it is danger. And sir, because of that, Dabawala got Six Sigma certification. Yes. I'll tell 1 minute story of motivation story of Six Sigma. So long back, 4 learned people came from Delhi to Mumbai, and they want to research on Dabawala. They researched 4 days and went back to Delhi. After 3 months, they called from Delhi, Dabawala, you got Six Sigma. Dabawala, I don't know what is Six Sigma. He told, man, it's a very big honor. Dabawala told, what to do? It is for you. Dabawala told, okay, send. Now this man told, man, we cannot sending. It's a big honor. You have to come to collect. We are coming to Mumbai. Please come. It's a very big honor. Now on the day of honor, Dabawala want to go to collect that honor. But Dabawala confused. He told very big. Now Dabawala don't know how much big. Because to tell very big, they went to collect 16 Dabawala to Six Sigma, very big honor. And they went to the dais, they have given Six Sigma certification. I remember President Raghunath Medke, he told, what is this Six Sigma? Other 15 Dabawala told, we have wasted 4 taxi charges, it is useless. They told, man, don't say like this. You are the first Indian company who got Six Sigma. That is Mumbai Dabawala. Sorry friend, today we call our recognition. Sir, you will recognize if you work consistently, 100% recognized. Sir, no technology. Of course, I'll go fast. Sir, 20,000 earning. Sir, 1 month bonus. Even customer don't pay bonus, they will continue because they want to make customer eat food. Sir, that's why no strike record. Anyway, friends, I'm not emotionally, but what we speak about customer satisfaction, actually we speak work satisfaction. Now, who know about customer? Sir, I have done research, 9 years research on Dabawala. I got doctorate on this subject. I have hundreds of examples, but very quickly I'll tell you a couple of examples. I asked one customer, can you tell me how Dabawala work? Customer told, they are excellent. Well, what excellent? Tiffin is your, food is your. They simply deliver. Customer told, they don't simply deliver food. Customer told, sir, when I leave 6 o'clock, sometime our customer forget his mobile spectacle at home. Then 9 o'clock, customer wife put husband mobile in lunch box. And Dabawala deliver along with food, mobile in office. They give value-added services. Another customer told, they are very honest. I told, how they cannot dishonest? They cannot eat your food. Customer told, sir, when I get salary in cash, customer cannot carry salary in cash in pocket. Get company thrown in crowded local train. So what do you do? After eating food, when I get salary, he put salary in empty tiffin. Dabawala deliver empty tiffin with salary in the hands of customer's wife safely. Because in 134 years, Dabawala never opened tiffin. Customer trust. Sir, customer. So not money. Sir, some Dabawala put gold, silver. Some Dabawala customer's wife put love letter. What not they put. I have very good examples of medical students I cannot share now, time constraint. But I'll tell one example about love letter. Many people must have seen that Lunchbox movie. But don't compare that because in our business, our customers send love letter, wife send love letter, but own husband, not someone else. I'll tell you one example. You will love to know. I asked one customer, he told, Dabawala God for me. You know what happened? That husband fighted with his wife one day evening. And sorry friend, Indian husband knows our quality of husband. Banda Indian husband tootega, lekin biwi ke samne jhukega. See how I told our Indian husband will cut down but never bend down in front of wife. Number 2, Indian husband angry young man. Next day morning his scold wife, divorce. 6 o'clock he went. 9 o'clock Dabawala came home. Indian wife, dile ke manta nahi. Despite dispute, she delivered tiffin 9 o'clock to Dabawala. Dabawala delivered in office. In lunch time, husband saw the tiffin. Morning angry young man become the hungry young man. When husband open a tiffin, on top of tiffin, return love letter from wife. Oh my beloved husband, I love you lot. Forget what happened in the morning. Eat my food, it is for you. Message given by wife to husband, delivered by remaining story. Husband eaten food. अब खाना खाने के बाद मैम उसको शर्म तो आती है. Husband shame himself. He brought 2 cinema tickets, put in empty tiffin and returned love letter to wife. साहब मैं सवाल पूछता जवाब देना. दो आत्मा का मिलन करने वाला. Friends, in my family 6 doctors are there. Believe me friend, I'm not talking emotionally to you because you are doctors or medical healthcare people. Sir, I told in the beginning only, when you save someone's life, sir, whole family, maybe many people you give satisfaction. Despite the fact, maybe me, maybe you, we are taking all these services by taking money. It's not about social work. But despite, if we don't do honestly, if we don't consistently, sir, it's not good. Of course, I have many things to share, but our disciplines are there, attitude is there. I'm showing one video. See how they are carrying. Sir, आवाज देना. 62 years, 70 years, 80 years.
Values and ethics.
Badao.
They are engaged in the business of
72-year
collecting
man.
tiffin boxes filled with homemade food from different houses and distributing them at the workplaces of the earning members of these families in the pre-noon.
So this man is 89-year-old. 89-year-old man still working. Can you imagine this? So what is this? Passion. Sir, I'll tell you about coding very quickly. When I'll tell coding, you visualize my local train map. Please friend, it'll take a minute and I will explain one tiffin coding. You understood 200,000 tiffin coding like this only. Right? I'll start. Sir, what is VLP? Residential area of customer. Ville Parle. Recognize my local train map. And what is Mr. E. Jhabawala? The man who will collect this tiffin from this area. And this tiffin will go to Nariman Point, number 3. It will start from Ville Parle. Remember, Ville Parle, Dadar, Grant Road, Churchgate, Nariman Point. After mixing 4 to 5, 6 hands, it will reach Nariman Point. When it will reach Nariman Point, who will pick this lunch box? Mr. 9 Dabawala. He will deliver EX call Express Tower, 12 call 12 floor. Because this customer office is on 12 floor. Without name, address, tiffin deliver. I know some people looking D'Souza. Sir, D'Souza is a customer. And who returned this name? Mr. Customer D'Souza could not recognize his own tiffin. He writes name. Friend, customer may not be knowing. We know our customer may be doctor, may be teacher. That's a business. That's a business. We should know our customers. Sir, you will see that how they do coding. Sir, simple piece of paper, simple matchstick become the brush. Sir, imagine. Resources may not be available. They use their resources which are available. So what is this? Sir, nothing else. You know what this man is doing? Sir, when you clean tiffin at home, sometimes our coding is not visible properly. If any Dabawala comes to know coding is not proper, he will remove color from pocket and with finger he will overwrite. He will not say, this is not my job. He will do the job. Kyo? Karna hai to karna hai. So we should do it. I was listening Mr. Manoj, then Mr. Sanjay, many speakers, of course. Then I listened to all panelists. Sir, see, everyone was telling same thing. अब क्या करें, हम human being है, हमको बार-बार बोलना पड़ता है. करेंगे? Sir, करेंगे. Yes, really, friend. I'll just give 3 videos very quickly.
That 200,000 of them are having it on all working days on time, thanks to the Mumbai Dabawalas. Watch the spontaneous sorting. Everyone is picking up his tiffins as per his delivery areas. Tiffins for areas with more density are transported on carts collectively. Some tiffins are on bicycles. One tiffin box shifts hands in transit at least 6 times before it reaches its consumer in his office.
Sir, standing near the running local train, doing sorting because they want to
tiffin.
deliver. Friends, let me tell you, There are some women who are working as of now. You know what women Deepavalis are doing? They are delivering school students lunch boxes. Why? Ma'am, female collecting 40 lunch box, 40 children and deliver only one school. So she not really delivered in maybe local train travel, no need. And now we want, why not Dabawala wife come into cooking? Because nowadays in Mumbai, husband and wife both are working. Now people worried, Dabawala worried, our business will come down. I told man, previously husband was customer, now wife also customer. Both will deliver. You start to cooking, anyway, many things, but really friend, it's our, see, before 100 years, how they were, maybe rainy season, sir, see, 8 million people travel every day in local train. 8 million boss, 80 lakh log travel karte. See, overcrowded. And just, it's affects, and because of that, many TV documentaries on Dabawala, M TV, A TV, A to Z TV. And many recognition. Sir, Six Sigma, Guinness Book of Record, we are got ISO certificate without application. Pata hi nahi kidhar karna hai. These people come to recognize. Sir, why? Sir, our recognition, only one, customer satisfaction. It's my privilege. I told I didn't doctor on this subject. I don't have time to speak on me. Last 5 minutes, I want to speak on Prince Charles. You know, sir, before Prince, actually in 2003, Prince Charles supposed to come to meet Dabawala. Before he's supposed to come, 6 months prior, British consulate called Dabawala. Dabawala, Prince Charles want to meet you. Dabawala told, I don't know who is Prince Charles. He was not knowing. So they told, he's a king of London. Oh, king of London. Dabawala told, okay, we will allow him, no problem. But with 2 conditions. Number 1, we will give Prince Charles only 20 minutes because Dabawala said we are busy. Number 2, we will not go to Prince Charles. Prince Charles should come to us. Where? Church get footpath. Consulate told, how speak like this? You know what he replied? बोले साहब वो लंदन के राजा है हम उनकी इज्जत करते हैं लेकिन 2 लाख कस्टमर महाराजा है we cannot disturb our your learned speaker were telling same thing customer sir when Prince Charles came to them they spoke like this he told I will come and he came and from that day Dabawala recognized globally. We started to believe God to Prince Charles. Prince Charles started to believe friend to Dabawala. And because of that, Prince Charles invited 3 Indians for his marriage. Sir, among 3 Indians, 2 were Dabawalas. Now, when Dabawala started for marriage to go, before one day to start, they got one bad news. And they refused to go to marriage. I told man, what happened? Dabawala told, sir, we are going for marriage. But what is bad news? Sir, this is 2nd marriage of Prince Charles, which is not good. As per Indian culture, 2nd marriage is not good. I was in tents. I was following Buckingham Palace. I got idea. I told Dabawala, you are invited for the first time. For Dabawala, this is first marriage. Oh, then we will go. Then we believe Prince Charles God. So we wish for long, happy married life. So no 3rd marriage. Like that, sir. Sorry, every photo is a message. But last 3 minutes, friends, I know that maybe Richard Branson, maybe many Francois, many places we went, friends. Maybe, of course, doctors, many. I know this is what, morning someone met me about this seminar, conference, wherever we go. Sir, really, we want to message you. Sir, even we are into some social responsibilities. Maybe, sir, Swachha Bharat Abhiyan, maybe HIV AIDS. Sir, I'm proud to tell you, not proud, satisfaction, that when Prime Minister in 2014 announced 100 brand ambassador for a Clean India movement, it was announced and I was one of them, one of 100 people who has a brand ambassador. And sir, till today we are working. Sir, maybe yoga, yes, you will love to know this concept. Sir, in my research, when I came to know, when Dabawala collect empty tiffin, listen carefully, how you can by default do many good things. So when I know that Dabawala, when you collect tiffin, sometimes some customer don't eat food. Why? He may not have time. He might be eaten. I told Dabawala, till this tiffin will go home in the evening, food will not be eatable. So what to do? So they told we are not allowed to open tiffin. Then you can go on YouTube and see Share My Dabba. So what we have done, sir? We made one sticker called Share My Dabba. And we distributed 10 stickers to those customers who do not eat food sometime. We appeal them. Sir, when you do not eat food, you want someone can eat, Please put Shermat Dabba sticker on it. Sir, as of now in Mumbai, 800 street children eating this food, not eaten by customer, delivered by Dabbawalas. So why don't you waste everything? Sir, you should not waste anything. And we started Roti Bank, so then Kapda Bank. Sir, of course, it's my privilege. These are 20 qualities. I will put 10 seconds on this screen. Please read out. And I want to ask you, is there among us any single person do not hold any one quality? Sir, I bet we hold more than 20 qualities, provided you should bring into practice. So without that, you cannot come to know what you are giving. So really, it's my privilege. I run education center. So before 16, 17 years, I told Dabawala, you should learn computer. They went out ready. 1 year I was after them. 8th of the year I got idea. In my school, I made wooden local train. In every coach, I put PC, invited Dabawala. Dabawala told, it's a local train. Now we are coming. I told Dabawala, you should know English, because in Mumbai, our customer from Chennai, Bangalore, maybe of course China, I know many countries, these people, customer don't know Hindi, Marathi. I told you should teach English. Teach English, I made wooden classrooms of local train. And now they are sitting, some people inside and running local train. Sir, really, I am not just presenting. Sir, believe me, last 22 years, I am providing education to 5,000 underprivileged children. And that's really story. Thank you so much. Thank you so much. Thank you. My time is over. Thank you, friends. Thank you all. Thank you. Thank you. Please be seated. I really folded hand, thanks you. Now, organizer, ma'am, my time is finished. No, but what? Before you honor me, I am expecting you will honor me with something. I know that. But before I receive, I want to honor some people. Dr. Harish, doctor, यहाँ हमारे बाल वाले डॉक्टर थे, वो बड़े बाल वाले डॉक्टर. He has went. Sorry, yes, sir, please. Yes, I could not pronounce your name, but friend, I brought some cap. I want 10, 12 people as per your time. I will give very quickly, and very first person will be difficult to wear cap, but I will wear him. सर आइए ना, भाटिया साहब, सॉरी संजय साहब, मैं नाम नहीं लूंगा, प्रतीक जी या डॉक्टर आपका जो भी है, आई वांट प्लीज. अरे सर, हमारे बहुत अच्छे दोस्त हैं, बड़े भाई हैं, लेकिन इनको तो ज्यादा जचेगा. Ma'am, can I request you to hold this?
Of course.
Please. Sir, please. Thank you so much for listening me. I want to make... Sorry, when even 1 or 2 females can come, female doctors or healthcare, I cannot take name, but yes, ma'am came to hold. Arre sir, ye dekha. Wow. He will take selfie afterward, I am sure. Thank you, sir. Thank you so much for listening. Thank you, sir. Thank you. Thank you, your elder to me. Please bless me, sir. Jai Hind, sir. Jai Hind. Jai Hind, Jai Maharashtra. Sir, you are handsome. In this cap, you look more handsome. Thank you, sir. Dr. Kelvin, 100%. You also come, boss. You told 100%. Oh, smart boy, hai na? Bhale CEO, I am sorry, I know, but so I remember your name. And when you speak about our 100%, so I certainly remember your name. And your hairstyle is very good. Thank you, sir. Thank you. Friends, so just a minute. I brought one more gift for these people. Friend, I brought small lunch box. And I know you are giving claps, but you will tell, not you will tell me bloody, but man, why not bring for we all? Friend, this small lunch box I have brought for all. I'll give to all. I will request organizer to distribute to all. Sir, I'll give very quickly, please. Thank you, sir. Thank you, sir. Thank you, doctor, sir. Please convey my regards to our organizer committee. Thank you, sir. Thank you. Thank you, sir. Thank you, sir. And ma'am, sorry, I forgot to give cap, but take. Can I take one photo? Yes. Sir, can you show tiffin? Not marketing. Photo अच्छा आएगा. Friend, you must be knowing, Dabala I am in two mode of transport. One is bicycle, one is a local train. I cannot bring local train, but I brought bicycle.
How loud?
And with your summit logo.
Oh, wow.
I don't know to whom I should hand over. To whom I should hand over. Only one bicycle, cannot everyone. Sorry. Sir, please come on the doctor.
Inviting
sir,
on
you.
stage Dr. Narottam Puri.
Thank you, sir. Thank you for coming. Please, sir, please. And friend, along with sir, sorry, last gift.
Sorry.
Sir, I written one book on Dabawala, which I have given to Buckingham Palace Prince Charles. I want to hand over a book also, sir, along with bicycle. Please. Thank you so much. Thank you so much. Thank you, everyone. Thank you, sir. Thank you, please. Thank you, sir. I'll be in back.
Dr. Pavan, if you and Dr. Narottam would please stay back.
ये बैग में दे देना. Thank you, doctor. Thank you so much, sir. Sir. Sir, that's a very love. Not anyone. Think gift is there. So nice of you. Thank you, sir. Thank you. क्या है ना, आज मैं 6 डॉक्टर घर में हैं, मैं सबको फोटो बाहर जाते से भेजूंगा तो थोड़ा और ऑरा मेरा बढ़ जाएगा घर में. हाँ. Thank you, dear. Thank you.
Thank you so much, Dr. Pavan. I'm usually not speechless, but I am currently. Nevertheless. So this actually brings us to the very end of our sessions, where we're now going to have the winning presentations. The winners come up on stage. For some reason, I seem to have misplaced the... Oh, there it is. There we are. So our first prize winner is Tay Wee Pin from Malaysia. And he will be presenting Project Polaris.
All right, thank you, MC. Namaste and good afternoon, everyone. My name is Wei Pin from Gleneagles Johor Business Development and Transformation, or we call it BDT department. At Gleneagles Johor, we always put patient first, which drive our commitment to challenge the status quo. Today, I'm excited to present our project, Project Polaris, Transforming Patient Journey. This project focuses on 2 key departments: the emergency department, the first point of contact for patient, and our business office, which manage the patient journey from arrival to departure. Our team unite leaders from both departments to enhance the patient care. Ladies and gentlemen, over the years, our hospital has aimed for a seamless patient journey. However, closer observation revealed that some of the process has inadvertently impacted patient experience. With an average admission time of 2 hours and 57 minutes and discharge time of 3 hours and 8 minutes, have you ever considered how each minute impacts patient care? Here, we discover several challenges. The admission and discharge information are often disjointed. There is a lack of standardization in our process, resources are not being optimized, and there is no active management behavior on the ground. By putting patient interests at heart and addressing challenges like long waiting time and underutilized resources, such as our bed occupancy, My team and I initiated interviews with department heads across various areas. Prior to our intervention, 48% of our negative feedback are waiting time related. And these are some of the negative feedback we have collected. We can observe that there are patients who are unaware of what is next in their process. The process are taking way too long. Our goal was to pinpoint challenges and develop targeted solutions to enhance efficiency and patient care. The recurring outcome in most, if not all situations, is a focus on insufficient headcount as the root causes. Consequently, our recruitment effort persists to firefight the situation without delving into the underlying issues and devising sustainable solutions. Therefore, we conduct a day in the life of, or we call it as a DILO, a study involving an assistant manager from the business office and a senior staff nurse from the emergency department. The study revealed that administrative tasks consume valuable time and reducing their active supervision. What we aim to prevent above all else are the repercussions of the reduced patient satisfaction stemming from prolonged waiting time, thereby compromising the hospital image and diminish staff morale, high turnover rate, and underutilized resources. Before I continue, here is a snapshot of the 5 key pillars of operational excellence in our project approach. The first, we examine the process. This slide shows us that the admission and discharge process at a high level are pretty straightforward. However, the underlying back-end administrative process is immense. We map each department roles and responsibility using a brown paper swim lane diagram. Our analysis revealed that there are 125 activities in the admission process, which group into 18 time blocks and taking approximately 2 hours, 57 minutes from the consultant visit to ward arrival. What is more surprising, the discharge process has 160 activities condensed into 27 time blocks and taking 3 hours, 8 minutes from the consultant ward round to the completion of housekeeping. The next pillar here is the management operating blueprint. This pillar focuses on the team planning, controlling, and reporting of performance following the continuous PDSA, Plan, Do, Study, Act principle to facilitate the institutional learning. Our team observed management behavior in the emergency and business office, finding many leaders lacking in the reporting function and failing to address performance deviation effectively. Moving on, we study on the organization structure. As you can see, both departments have ineffective span of control. These highlight the needs for optimized communication and oversight. And the next, we look into the pillar of people. In the emergency department, to address the insufficient manpower, the team conduct a patient volume study against the allocated resources. The graph shows a consistent trend between 2022 and 2023. We are in view that a dynamic scheduling, aligning the resources with the patient volume will be effective in addressing this issue. Ladies and gentlemen, process necessitates system, and the system thrives with the efficient process. To monitor the success of the process, we need reliable measurement tools. It was found that there is no tracking system to report the admission time for each patient. This is alarming as we can't manage what we can't measure. On the other hand, discharge tracking system has been implemented 2 years ago, but the system was not fully utilized. With the findings above, the project objective is to reduce the overall admission and discharge duration at Gleneagles Hospital Johor by 50% within 40 weeks from March to December 2023. This will be achieved by optimizing the resource allocation and reducing the turnaround time for bed allocation. Based on our Ichikawa diagram analysis, we found that 6 potential root causes, and these root causes are then prioritized using the impact effort method. A primary issue is the repetitive process, indicating the need for process re-engineering. Another significant cause is the lack of visibility on bed readiness and patient journey, which led to the establishment of the Central Resource and Coordination, or we call it CRC department. Additionally, the team addressed ineffective performance measurement by implementing management operating blueprint to evaluate the system compliance, service timeliness, and work quality. And finally, we restructure both business office and emergency department. The CRC department inspired by air traffic control principle from the airport. And this I started with the serving as the central point of reference for each stage of the patient journey, from forecasting the pre-admission to the end-to-end process of patient admission and discharge. As part of the internal talent development, we have selected the former assistant manager in business office to lead this department. The CRC department has 10 staff redesignated from business office. With the admission and discharge tracking system, we set up our command center. A CRC department SOP was signed off to ensure the department's sustainability. With our first intervention, began with the process re-engineering and the formation of this CRC department. We introduced a new way of working through a complete overhaul of the process and out-of-the-box thinking. Simulating the journey of a hotel check-in process, the CRC has now full visibility of the patient journey, including the potential number of admission and discharge for the upcoming days, enabling the CRC to plan the resources ahead of the patient admission. This allows us to introduce bedside admission, thereby reducing the patient waiting time significantly. Ladies and gentlemen, with our intervention, we have removed 53 activities in the admission and 61 activities for the discharges process. And this new process allows us to reduce 38% of our turnaround time for admission and another 28% for discharges. With the bedside admission and discharge, patients are directed to their room upon the arrival and bypassing all the lengthy process in the lobby. And for discharge, with the enhanced visibility into the patient journey and leveraging the insight from the broken window theories, the CRC implements short interval controls to streamline the process. With our first intervention, the discharge time began to reduce from week 18. This new process now enables the staff to track the patient journey in real time, with CRC stepping in for short interval control as needed. For admission, the intervention began in week 28 due to the development of the admission time tracker. Similar observation as discharge, the new process allowed a quicker turnaround. However, my team has observed that not every staff in the business office and emergency department are fully aware of the new process. The supervisors are not able to supervise every staff due to the high workload. And hence, we implement the MOB in both business office and emergency department. The individual department's activities are tracked and reviewed regularly and allowing the managers to address deviations swiftly. We also revamped the organization structure to optimize the span of control at each level. As a result of this initiative, we have reduced the weekly average admission time to below 2 hours 57 minutes. Through continuous monitoring and regular audits, we have achieved and maintained the admission time below 1 hour and 29 minutes. In this slide, you will observe a similar process for our discharge timing. Following the same PDSA principle, we have determined that the project has effectively met its target and consistently remained 1 hour 34 minutes to date. And by decreasing the bed turnaround by 50%, we maximize our resource utilization and increase the bed occupancy rate from 77 to 90% without adding new beds. We also managed to reduce our negative feedback from 48% to only 27%. Ladies and gentlemen, this project marks a significant milestone, but our journeys continue. While IHH emphasizes sustainability, we are committed to evolving and improving as we care for our patients, our people, and our public. With this, we will institutionalize our learning and expand the CRC as the hospital grows its patient volume in Malaysia. Regular audits will ensure we improve and avoid backsliding to the old processes. Besides, we have also initiated a preliminary discussion with our sister hospital, Pantai Hospital Batu Pahat, in replicating the similar setup. Therefore, we encourage and ready to support any other IHH hospital to adopt and establish an operational command center just like our CRC department. Ladies and gentlemen, Dayavat, thank you for joining me on this journey to enhance patient care.
Thank you. That was actually a very succinct presentation. I'd now like to call upon Grace Chan, hi, from Hong Kong, who's going to talk about cashier navigation.
Namaste, मेरा नाम ग्रेस है मैं हांगकांग से आई हूँ Good afternoon, everyone. This is Grace from Gleneagles Hospital, Hong Kong. So actually, after the best speaker sections, I don't know how to continue these sections. But anyway, thank you for Wei Pin for bringing up our sections to start. So thank you very much. So I'm proud to be part of my team to show you our projects on cashier navigations, guiding patient expectations. Although waiting was not explicitly mentioned here, but indeed, like what Wei Pin teams was focusing on. We are focusing on managing patient experience around cashier waiting time. So to hospital, patient waiting at the cashier to pay indeed was a happy problem. But for patients, any waiting is too much to handle. And for staff, it is as well stressful. Is whenever you see the overwhelming area. So in earlier 2023, GHK has a real wake-up call on the queue situations. Business is indeed growing, but yet with the negative comments also growing at the same time. And NPS fall below our annual targets. That's why we gathered the projects team here with operational excellence and business office, radiology, and service excellence to tackle the problems together. So let's rewind the clock a little bit to 2023 May. So on the graph on the right bottoms, you can see the black lines represent our growing business. That looks really good. But then on the yellow lines, that's our NPS score. That fall below our annual targets are deep back in May. And those stacked the bar right there, you can see it's growing as well, but that was the negative comments that we received on our cashier and pharmacy from our outpatients. It increased by 50% compared to May. May and March, some tangible issues was mentioned, like the waiting times, unhelpful facilities, and unclear instructions were mentioned by the patients. We also tracked some numbers on those peak hours, which focus on noon and late afternoon, which you can imagine is that probably the times that before the doctor go for meal breaks. So all the 13 clinics, emergency rooms, and allied health units were all discharging patients at similar times. Here we are talking about 45 cases on average per hour, all trying to get checked out at our 2 cashier counters. We also identified that 60% of the settlements were coming from patients without medications, which radiology was one of the top departments with such types of bills. And we still wish to keep up our growing patient numbers. These projects become a priority for us. In the 6-month time frames of these projects, our goals are to manage patient expectations, which in turn will bring down the overall negative comments and also push back our NPS up to 5%, restoring them to our annual goals. All right, so time to identify the root cause. First, our project team revisit our outpatient flows to understand the bottlenecks, building up the fishbone diagrams on the right, highlighting some specific factors contributing to the top 3 tangible negative issues we identified earlier. All right, so for validations, let me take you to a quick tour to our lobby in Hong Kong, which we can do next year. So now you can visualize a little bit on our actual pictures. So on the left, you can see our inpatient counters. So 7 of them to handle the inpatient for both admissions and discharge. On the right, another 7 counters, which seems to be quite fair, but the trickiest part is 5 of those dedicated to dose dispensed medications. That's only leaving 2 counters to handle all the billings for outpatients with and without medications. Just imagine the peak hours at around noon. The third batch of people also count into the groups. Those are the inpatients who come to take their drugs. A step back, we've noticed the extended waiting area outside the counters is yet to be well utilized. Patients tend to be very close to the cashier counters for a sense of security, like not wanting to miss their turns. Besides, patients are constantly getting confused with the signs and arrows in the lobby. We mean to be very informative, but happen to be quite overwhelming for them. Patients may wander into the wrong queue or head to the inpatient counters by mistake. And let's not forget the roadmaps we're given to outpatients to show their ways after consultation. Those routes with and without medication, which are quite different, were yet listed as a single items on the single lines. Although we may have circled the options, but it was way too much for a 6th person to read. All right, so let's deep dive to the solutions that we have been implementing to address the patient flow challenges. Our first intervention, focus on defining and optimizing the waiting area by creating distinct zones. Inner zones we would like to reserve for patients with medications and outer zone for those without. We strategically place the ticket machines for non-medication queue away from the entrance of the inner zone so they are less inclined to enter the area. And then we took a step further by assigning our service excellence team to act as a triage during the peak hours, adding a bit of human touch guiding patients to the right queue. We also identified the outer waiting area with clear labeling. We added the charging stations. Not only does this use the battery anxiety of patients, which can also distract them from their phones, this also encourages patients to stay in the designated zones, keeping the pathway clear. By chance, we have a marketing collaborations with a vendor to bring in a robot for engagement, which helps a little bit to divert attention. So during trial, we are glad to observe that patients are more self-navigated. The cashier counter also reflects that there is substantial decrease on inquiries about queuing procedure. Now our second intervention, diverting payment at the service unit. While we had identified radiology as one of our top departments where patients doesn't have medication, the team has redesigned their workflow and counters to encourage on-site settlement. As the graph shows, payments handled by radiology team has significantly increased, as shown in the longer orange bar right there. This shift an average 40% of single payment away from the main queue at the lobby. In the trial stage, we also interviewed the patients and all of them were satisfied with the payment options. They were glad that they can be kept away from the long queue at business office and the payment can be done within 5 minutes. Our observation also showed that 70% of government-referred clients were elderly, who often require more extensive imaging. The one-stop shop service have kept them away from the long process, significantly reducing the overall time required in the hospital. Here come to our third intervention, optimizing our business office resources. Remember the 7 counters on the left-hand side of the lobby? They are now more engaged, as we have the designated BO in charge monitoring the outpatient queues and assigning tasks for each counter whenever needed. We also have the call bell installed at the outpatient counters and staff at the triage can help to sooner assist them whenever the queue got stuck. In the graph, you can see that the hourly capacities to handle payment increased, resulting in fewer bills need to be processed later. And of course, we put efforts to review the instructions, separating out the pathway for med and non-med patients into 2 rows on the road maps. We also clearly labeled the kiosks and the signage at the lobby. Overall, we optimized every step along the process to make the patients waiting at the right queue and at the right place. After the PDSA cycle, we are pleased to report that we have met our targets. The negative feedbacks have dropped below 55%, and we've successfully pushed our outpatient NPS goal back to 53.6, ahead of our annual goal. In the long run, this project has not only increased our capacity to serve more patients, but also improved their waiting time experience, leading to our highest satisfaction levels reflected in our NPS score. In summary, we meticulously embedded our new waiting time solutions across departments, from detailed work instructions to daily task lists, even staff roster. We will also conduct regular review on signage. And of course, patient feedback remains as one of our most invaluable control tools. As discussed, perceptions of waiting time can be varied. While one person may see a quick 5 minutes, and other may see an eternity. While we are also working to make things faster, zero wait time is not quite possible. So it's about how to manage the expectations. Echoing our initiative, developing the patient mobile apps like My Health 360 in Singapore and Malaysia, or My Gleneagles Smart Health in Hong Kong, patients nowadays would like to be in control of their healthcare journey, like to access their reports and schedule instantly on their palm. So what about waiting time? While we can't eliminate waiting, we can empower patients to feel like in control by providing them with clear information, guidance, and comfortable area. With the help of advanced technology like payment kiosks and queuing system on the way, we, GHK, is confident to have our business continue to grow without any trade-off on our patient satisfaction. Last but not least, I'm looking forward to see you all in Hong Kong next year. Thank you very much.
Thank you very much, Grace. Our next presenter is Lavina Lal from Fortis Healthcare India, and she'll be presenting on improving patient experience through collective collaboration.
Very good afternoon. The last presentation for the day. I think that should excite you, some smiles, last one to listen to. Can I have the presentation? All right. So this presentation and this project is slightly different because usually when you try and attempt a presentation or a QIP project, we start to look at a specific cause and try and go down to a micro level and fix it. What we did here is we went actually to a macro level and saw, can we fix a system by using the same people who are working and are part of the system. So we are talking about improving patient experience, and we said that we want to create harmony through symphony. That was our theme, and this was the team that worked on it. As I said, harmony creating symphony. What was our concern? NPS. My previous colleague also talked about NPS, which was the outpatient NPS. We talked about the inpatient NPS. And inpatient NPS has more than 10 components to it, which is your admission experience, your discharge experience, your food experience, nursing, medical, just about everything. And our scores were at a very dismal, which was about 40% odd as an average over the last 6 months. And we said, we are so low at 40%, let's try and see if we can improve it further. And including our complaints, which were also on a rising trend. We're talking about inpatient NPS score. To give you a current existing workflow analysis, what was my current process? How did this patient experience work? So there is a patient experience team on every floor. One of the team members are kind of allotted at different departments, and they will go and meet the patients, take their rounds. If they have any concerns, they will address, they'll coordinate with the different HODs and try and find out a solution for it, do a RCA, do a CAPA, and close the issues. And on a discharge, they'll meet them, say thank you, talk about the feedback. This is the traditional patient experience team that we have. It's very reactive in nature. They go and come into presence only when there is an issue that is happening. So what was going wrong? Why are we still at such a low NPS? So underlying to this process, there were some basic fundamental gaps that were there. Complex processes, many stakeholders. All of these 10 components that I'm talking about involves almost the entire hospital. Lack of collective ownership. We do have ownership at individual department levels, but is somebody going at a macro level, seeing it from the patient perspective? Is there a collective ownership amongst the entire team? To give you, say, a number to collective ownership, I'm talking about 1,500 employees right now at our hospital, which is a 400-bedded hospital. Lack of teamwork as a routine. You may find teamwork as within the department, intra-departmental, nursing may work together. You go to critical departments like an OT or an ICU, you'll find very good multidisciplinary teamwork, which is a routine. But you come down to a ward where all these departments are scattered. Is that a routine? Very difficult to do. Unintentional blame shift. I placed the order, the FMB did not deliver the food. I called for the housekeeping, they did not turn up. That's an unintentional because that's not their job. They're just coordinating. Lack of collective monitoring. Are we monitoring them as a whole or are we monitoring them as departments? Lack of empathetic culture. Now this empathetic culture is not for the patient. I'm talking about empathetic culture between the employees. Are we empathetic towards each other as departments? Quick fixes, which do not sustain as there is no focus on process improvement. Again, I'm talking about a process from a patient's perspective. So we wanted to improve our net promoter score. I've already told you we were pretty low. We were averaging about 80, 85 complaints in a month just in the IPD department. So we thought, let's try and improve it and make it about 50%. We were pretty unsure. We said, okay, let's say a 20% improvement. We are at 41. Let's try and at least reach 50, what was we targeted. Our aim was to achieve this by making patient experience empathetic, team-driven, collaborative, and efficient. We did a lot of RCS, and traditionally when you're looking at RCS or fishbone, we usually have departments. So you'll have all nursing-related issue parked in the nursing departments, all FMB-related issue parked under FMB department. We reclassified them. What we saw is, how is the patient seeing that? And we thought that we should give bigger themes around it. And it was not a surprise. 80% of our complaints were actually falling under the bucket of communication, and communication between different departments. Doctor did not come, when did he come, was the report explained? All of this came under this communication pattern. So top 4 issues. One was communication between different departments, leading to delays in services. Discharge intimation. Discharge will always feature when you talk about patient experience. I don't think so we can do away with that. So we thought intimations were coming throughout the day and the team is constantly only driving out patients and driving each other mad. So that was really not working well for us. Call bell delays, again, nursing. Behavior, which is rudeness and language barrier, which kind of was across departments, not just specific to one department. So we picked up 4 aspects. We picked up on communication, we picked up on discharge, because again, multidisciplinary. We said, why are nurses busy? Why is there a delay? Let's address that. And we also talked about behavior related, whether it's language barrier or rudeness, can we address these? These were how we looked at it, and we said that all of these different areas, we will address it differently. First one we thought is, for discharges, we'll put up an early discharge intimation. Nursing, we looked at the nursing protocols, and behavioral training, we looked at how can you incorporate common training platform to make this empathy come out better. And as a common point, so again, I'm saying we're talking about 3-4 areas. How do we tie it down? So the main intervention we did is we repurposed our patient experience team who were already present, and we called them as flow managers. We said, you'd right now become part of the team rather than being on the outside and just communicating with the patients, figuring out what is their problem, going back and fixing their problems. Instead of that, can you become part of the team which is delivering the patient care? So that's what we changed over here. What did we make them do? This was the revised workflow. We, instead of having the process map from our perspective, so you have multiple swim lanes coming up, we said, let's take the patient journey map. And we looked at the patient journey touch points. And under each touch points, who are the people, what is the process they do, and how can we get them together on the same platform? So we talked about from estimates, financial counseling to admission, to diagnosis, to medical treatment, to surgical treatment, to nursing care, FMB, billing, discharge, and post-discharge. Across this continuum, we identified the people, and we said, what should this floor manager do? What is his how does he tie all of them together? So primarily, the old flow P person was very much, the approach was reactive. When the complaint comes, he'll go and talk. It was complaint resolution focused. It was problem focused. Go searching for a problem, fix the problem, and then come back. Department driven. Oh, FMB issue, let's go to the FMB department. Dispatch, let's go to the billing department. Individual ownership and hub and spoke model. So what's very specific to hub and spoke model is there is a hub and there is spoke. This communication is just unilateral, just between. But the spokes don't speak together. So how did we transform? We told them that you had to be proactive. Don't come in the picture when the complaint comes. You be proactive and anticipate. And for example, a lunch delivery system, you know that don't come up when the lunch is delayed. 12:30 is supposed to be the delivery time. Can you make a call at 12:15, coordinate with the team, ensure the trolley is already on the way? So become proactive, anticipate needs. Complaints prevention. Don't go for resolution. Can you move it to prevention? Process focus. Look at the process if you can improve it. Team driven. Get the floor team together. Collective ownership. And as I said, we wanted to make them the solar system. So the sun and the planets together. They all revolve around each other, with each other, to ensure they don't collapse along. Otherwise, we'll have another Big Bang theory. So that's what we trained them for. And what did we achieve? Definitely our complaints went down. Our NPS started moving because you started seeing a collective momentum happening. The team started working together. Our NPS touched 83 in June 24, which was the highest that we have, and is consistently above 75%, even today, as on today. Our complaints started going down. From 80s, we came down to less than 24. We targeted 50%, but we touched even 85%, and it is sustaining. A lot of, we had benefits to it, but I just want to highlight two such benefits. As we worked on discharge and we tried to make it a little simpler, we actually had a lot of savings in terms of the half-day room rent from the patient's perspective. We started discharging them faster, so automatically, their payment for that particular day, which was very complicated, and because of the delays, they were ending up paying, we started saving on them. We had a lot of, lot many actions are taken when there is, you have to pass away you have to do some service recoveries because there were a lot of complaints happening, delays happening. Those service recovery issues started coming down in terms of money, in terms of efforts, because the issues started coming down, whole complaints started coming down. Language barrier was one thing that I want to say, and I'm not talking about, we had a lot of regional nurses coming in. And this idea of training regional nurses in the regional language of Hindi, of which was very particular to Maharashtra, was a very innovative way of getting them onboarded, because most of them travel from down south and they don't understand the language here. Most of them are misinterpreted as rudeness and rude behavior, whereas it's not actually rude behavior, it's actually a problem with the language barrier. So we trained them on Hindi language, which is a part of the induction program, and that also helped. So we got the floor managers, to sum up, to tie up this team, the nurse, the doctor, the billing desk, the discharge desk, everyone together, and we trained them to anticipate for problems instead of allowing them to crop up. That was the fundamental shift we did, and that's what resulted in one of the best NPS scores that we have had in so many years since we've been driving patient experience. For sustainability, we developed SOPs and workflows across the departments, and we showed them how it has to be done. And each of this workflow was interdepartmental. It was not just for one person or one department, it was all together. We ensured that we created new KRAs for the PE team, because now it was not about, again, resolution, it was anticipation and driving improvements. So the KRAs were very much reflective of their work, so we ensured that you can monitor them objectively. Finally, we thought about, can we, the same thing can be implemented across different hospitals. I'm sure it can be, because there's not fundamental change. It's just the way they have been doing this work for such a long time, which we're shifting from being reactive to more proactive. So the same team who was now coming into the picture, into the scene only when a problem was arising, is right now placed on the floor, coordinating with all the departments and ensuring the situation doesn't arise. So that was what we did at Fortis Mulund. Thank you so much for the opportunity.
Thanks, Lavina. So before we close this session, we have some highlights from the day which we're going to play for everyone to see. So while they're getting the video together, there are a few announcements which I will make. As I had said earlier, you can access your photographs under the profile section in the app, the posters under the poster section in the app. So just I think you should be able to do that today, whatever. The posters already available, I think, and some of the pictures already available. The rest, the entire dump within 6 to 7 days. Please do collect, there are takeaways for each of you. Please do collect them at the registration desk that is at the Land's End Court. And I think for everyone that's going out for site visits, I think 2:15 is when they are moving out. So get your lunch and then you're ready to go. So that also will be at the registration desk. So I was told that the video has been queued. Is it queued? Yeah? Okay. Great. Thank you so much, everyone. This has been indeed a pleasure and an honor. And all the best and a safe journey back. You're welcome.